through you, Chair. We're live.
Good morning and welcome to everybody to the 9th hearing of Portfolio Committee number 2, Inquiry into Health Outcomes and Access to Health and Hospital Services in Rural, Regional and Remote New South Wales. My name is Greg Donnelly and I am the Chair of the committee in this inquiry. The inquiry is examining health outcomes, access to services, patient experience, planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I'd like to acknowledge the Gadigal people who are the traditional custodians of the land on which this parliament sits. I would also like to pay respects to elders past, present and emerging of the Eora Nation and extend that respect to other Aboriginals viewing this broadcast all around the state today. Today's hearing is being conducted virtually. This enables the work of the committee to continue during COVID-19 without compromising the health and safety of members, witnesses and staff. As we break new ground with the technology, I'd ask for everyone's patience through any technical difficulties that we may experience today. If participants lose their internet connection and are disconnected from the virtual hearing, they are asked to rejoin the hearing by using the same link as provided by the committee secretary to them. Today, we are hearing from a number of stakeholders, including private citizens, peak bodies and universities. I thank everybody for making the time to give evidence to this important inquiry. Before we commence, I would like to make some brief comments about the procedures today for our hearing. Whilst parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the virtual hearing. I therefore urge witnesses to be careful about comments you make to the media or others after you complete your evidence. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it's important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness according to the procedural fairness resolution adopted by the Legislative Council in 2018. There may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. Today's proceedings are being streamed live and transcript will be placed on the committee's website once it becomes available in a few days' time. Finally, a few notes on the virtual hearing etiquette to minimise disruptions and assist our Hansard reporters. Firstly, can I ask committee members to clearly identify who questions are being directed to? And could I ask everyone to please state their name when they begin speaking? Could everyone please mute their microphones when they're not speaking? And that's important in terms of the background noise. Thirdly, please remember to run your microphones or turn your microphones back on when you're about to ready to speak. If you start speaking whilst muted, please start your question or answer again so it can be recorded for the transcript purposes. Members and witnesses should avoid speaking over each other so we can all be heard clearly. And finally, it's important to assist Hansard. May I remind members and witnesses to speak directly into your microphones and avoid making comments when your head is turned away. I'd like now to welcome our first witnesses. Could each witness, and those two witnesses, of course, Ms. Hayes and Ms. Wells, could I ask each witness to state your name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which should be provided to you. So I might start, if I could please, with Ms. Hayes.
Thank you very much. My name is Elizabeth Hayes. I'm a journalist with the Nine Network. My oath, I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much, Ms. Hayes. Ms. Wells.
My name is Jamelle Wells. I'm a journalist at the ABC. I'm giving evidence at this inquiry as a private citizen. My oath, I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much to both of you. And can I commence by welcoming both of you sincerely. And I'd like to make some general comment just to set some context for this evidence which you're about to receive for everyone listening. These two women who are joining us now to provide evidence are well known to many of us, indeed many Australians. They are both well known for their lengthy involvement in the media, journalism, and the public square. They're highly regarded by their peers in particular, and the Australian public in general, for their astuteness, professionalism, and decency in the way in which they have gone about their professional work as journalists and commentators. They have highly well-regarded reputations. Both, though, and I'd like to make this point, both, though, are daughters of what were and have been and will always be outstanding men, senior Australians in this state who died in tragic circumstances. And it's really the basis of those experiences that both bring the evidence to the inquiry. The circumstances of their respective fathers' passings were tragic and difficult, and none of us would want to find ourselves in such circumstances. And I'd like to take the opportunity on behalf of the committee to thank you both for your strong public advocacy on the matters that you brought before the inquiry. And I have to say that it was the advocacy from both of you that, at least in part, perhaps not in any significant part, has contributed to this inquiry being undertaken. So I'd thank you both very much. We'll commence now then with an opportunity for both Ms. Wells and Ms. Hayes to make a short opening statement, which will provide maximum opportunity for the questioning by committee members. Can I note for the record that with respect to both our witnesses, your submissions have been received and stand as evidence to this inquiry. I'm sure you're aware of this, but Ms. Wells, your submission stands as submission number 351 to the inquiry, and Ms. Hayes, your submission stands as submission 613. So take them as read. The committee have got them, have read them and studied them. But I'll invite both of you now to make a short opening statement, then we'll be followed by some questioning. So perhaps if we start with Ms. Wells. Ms. Wells.
Thank you, committee, for asking me to speak today. My submission, as you know, is about my father, the late Alan Wells from Cobar. All eyes are on country towns in the state's west right now because of the threat of COVID. There's concern and panic about hospitals not having enough resources. It's even been called a humanitarian crisis. Well, this was a reality before COVID, and I experienced it with my 85-year-old dad 2 years ago. You know from my submission the ordeal that he was put through after being flown to Dubbo Base Hospital to have a broken hip repaired. And I thank the frontline staff who tried to help him, but they were unsupported in a big base hospital that was overburdened and under-resourced. There were signs from the start that the hospital couldn't cope, and my dad was treated like a bed blocker. He had 2 operations in 5 days after something went horribly wrong with the first one. The wrong surgeon's name was above his bed and in his records. Just hours after we fought an attempt to discharge him, he went into cardiac arrest. Staff then suggested not resuscitating him, even though he had a full resuscitation plan in place. My dad defied their expectations and he pulled through. What happened next was inhumane. Dad begged for food and water on a long weekend because a manager said the hospital could not afford to roster someone on to do a SIP test to see if he could eat and drink safely. Soon after that, I read a front page story in a Dubbo newspaper about a new $30 million car park for Dubbo Base Hospital. You have a copy of that story. How a decision gets made about using hospital funding in that way just beggars belief. I still can't get my head around it. My father's ward ran out of morphine, it ran out of Panadol. Staff were stretched beyond safety limits. An unsupervised junior ICU doctor fought back tears over the distress he caused Dad by 3 botched attempts to insert a tube in his nose. Staff with no geriatric care training wrote dementia in Dad's records, even though he never had any reason to be diagnosed with it, and he passed all hospital mental acuity tests 100%. Dad was bundled out of Dubbo Hospital back to Cobar by road ambulance in 40-degree heat. He arrived in Cobar at night and not to be returned was written on his discharge papers. He was soon discharged from an empty Cobar hospital too. The health service continues to be defensive. Staff tried to exclude my concerns from a review that was ordered by the minister. I was charged $600 for medical records that are shambolic. They have a blood checklist missing, records of another man mixed in with my dad's. I get daily correspondence almost from other families and overworked hospital staff in this area. They have some expectation that because I have spoken up, I can help them, and some of them are too scared to speak up, but I don't know how to help. What I do know, committee, is that my dad deserved better, and other country people deserve better too. Thank you.
Thank you very much, Ms. Wells, for that very clear and precise opening statement. Ms. Hayes.
Thank you very much. I would also like to thank the committee for this opportunity to speak. Although how I find myself here gives me no joy. You've read my submission, so I presume you too wonder how in a hospital in Australia in the 21st century, my father could firstly be overdosed on his prescribed medication and then unbelievably die after not receiving his essential anti-stroke medication. Both hospitals where my father was treated acknowledged their errors. Both said they would be making changes to ensure that what happened to my dad wouldn't happen to someone else's family. But here we are 2 years later, almost to the day, and I'm not filled with confidence. And now there's the other C word, COVID. How dreadful that it takes a virus that not even the biggest hospitals in Sydney can cope with to expose the substandard healthcare for people in rural areas. The people of the Manning region with the oldest demographic in Australia with the worst cardiac outcomes and a large Indigenous population have good reason to be concerned. Just isolating patients in their 50-year-old hospital will not be easy. More than a few patients with COVID, I'm told, would be a disaster. Staff are rightly nervous. The corridors of the hospital are so narrow, for example, they can barely do their jobs without physically running into each other. And then all the other regular horror stories and HCCC investigations continue. A woman was taken to Manning Hospital's emergency department. She told me, despite feeling very unwell and fearing she had COVID, staff decided she should go home. Without transport and living a half-hour away, she was handed a bus schedule. She lay on the grass outside the hospital while she waited for an elderly neighbour to come and pick her up. Her GP then had her admitted to Foster Private Hospital, where she spent a week being treated not for COVID, but pneumonia. And it's not just patients. I saw an internal email just this week talking of patient safety being compromised because of serious staff shortages. In that email, a doctor asked, why do we have to wait for a disaster to be reported to the media or the HCCC to act? So who's not listening? The committee heard in Taree evidence that at Manning Hospital, cleaners had been asked to sit with dementia patients. That was not something the CEO of the Hunter New England Health District, Michael D. Rienzo, thought was true. Yet I have cited an email from management at Manning Hospital saying staff should make use not just of cleaners, but wardsmen, administration staff, families, even other patients to be sitters. So why would Mr. Di Rienzo not know, or why would not someone tell him how bad things are? Since telling our stories, Jamel and I, as she said, have had literally hundreds of Morning Herald, Carrie Fellner. People are angry, frightened, frustrated, and feeling very alone. And if they're health professionals, they believe speaking out will cost them their jobs. It's my opinion. It's time for someone to own this issue. The buck must stop with someone, and that someone has to change the rural health model because it's not working. You know that, I know that. I'm sorry, but it's a very sick rural health system. Thank you.
Ms Hayes, thank you very much for that also very concise and clear opening statement. Now, we'll move now, if the witnesses are agreeable to questioning. We have witnesses from the opposition, crossbench and government, and with the remaining time, which is left to us through till 10 o'clock, we'll divide that time equally between the three groups, and the questions will proceed and will rotate through the three groups. So are you both agreeable to that format?
Yes.
Thank you very much. Thank you once again both for appearing. We'll commence with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair, and thank you, Ms. Wells, and thank you, Ms. Hayes. And I also wish to echo the Chair's comments at the very beginning. I know as daughters, it's very difficult for you to come forward. I know that you guys can take heart in the fact that the passing of your fathers played a role, and you going public in this inquiry and the establishment of this inquiry. So that's something that I think you should take away. And Ms. Hayes, I do acknowledge that tomorrow is the anniversary of your father's passing. So thank you for coming forward too, and especially at this very difficult time. You know that we make recommendations based on the evidence that we receive. And I guess I would like to know, you've been following this inquiry, both of you, and I can tell from your submissions that you've made today that you've been continuing to follow it. What recommendations would you like to see this inquiry make involving rural and regional health? Ms. Wells?
There are so many. I think the main thing that people who are contacting Liz and I are feeling is that they can't speak up about what they want. That includes patients, it includes grieving families, and it includes staff, most importantly, frontline staff working in regional health. They say they don't have enough resources. They say they are told to discharge patients too early. They say they have to work under management quotas and percentages and budgets that are dictated to them. They say they fear for their jobs if they speak up about what they need at the front line to get the job done. So the main thing I would like to see is more transparency and feeling people from staff to patients feeling that they are more empowered to speak up and tell it like it is, and for the area health services to not be so defensive about that. What we are getting in the media and what we've had since my dad passed away 2 years ago is this constant spin about how everything is all right. And Liz and I have been even portrayed by some as grieving daughters who can't let go. Well, that may be true, but we have had hundreds of letters and emails and phone calls from other people in our position in country towns, and they really do deserve better. They pay the same taxes as we who live in cities pay.
Ms. Hayes, what recommendations would you like to see? And I do have to admit that I rewatched the documentary on both your fathers last night, and sadly, a year later, and we are still in the same situation. Ms. Hayes?
Yes, it is sadly that we're in the same situation. I echo what Jamel says. We have had literally across the board, patients, health workers, you name it, anyone who's been within the health system come to us and ask us to tell their stories because they are fearful of speaking up. I was shocked at experts and doctors in particular fearful they would lose their jobs, and I wonder why. What has happened for an environment for everybody, where the common good is what we're talking about here, are frightened to speak up because of repercussions. So clearly, I'm seeing that there's a toxic environment where people can't speak their truth in a orderly fashion, obviously, but don't feel they don't trust the system. So they've lost trust in their ability to speak up. They don't believe that anyone's listening, and they believe there will be reprisals for speaking up. I also, I think we've found during our investigations, there is seemingly a disconnect. And I raised Mr. Di Rienzo only because I would think he would want to make things much better, but how come he isn't aware of these things? Why isn't somebody able to go and say, we've got cleaners being asked to sit with patients? What's happened that there is this conversation that's gone out the window? Bureaucrats, are they feeling as though they just have to take control of a massive situation and do their best, I guess? But in the end, what's happened? Why are people not able to speak up, and why don't bureaucrats or health ministers know about this? I'm shocked by that.
Ms. Hayes, in your opening statement today, you made mention of an email in relation to patient safety, cleaners asked to sit with dementia patients, and then you actually made the extraordinary claim that staff were encouraged, if they could find patients, to look after other patients or monitor them. How recent was that email? And I understand confidentiality, but is that a recent email, or is that from several years ago? When is that from?
That email that I have cited was in 2018, and it was sent to staff to say this is this, and clearly there was a meeting which took place to say things were not good. But I'm aware, so I investigated, I looked at this email which mentioned wardsmen, cleaners, administration staff, and not only that, other patients to maybe sit with other patients. And then I was told just very recently, administration staff have been asked to do that as well, secretary. So it's not like anything's changed. And the horror of that is not that people are being, well, the horror is that they're being asked to do it, but nothing's changed. Nobody's seemingly allowed to speak up. Or, I mean, I think if this was in Sydney, we do know, or Melbourne, or we do know that that would be a front page splash. That's just an appalling scenario.
Absolutely. Ms. Wells, now you mentioned COVID and people now describing it in Western New South Wales as a humanitarian crisis. Has COVID, in fact, put the spotlight on the state of far Western New South Wales and Western New South Wales health? And what's the latest information that you have?
It has, because people are now asking, why are there hospitals out west that have no permanent doctors? They're asking, why are people being triaged in hospital car parks? I heard, and you've probably read about the story a few weeks ago, a woman waited in the hospital car park at Walgett in winter for about 4 hours, waiting to get triaged before she could get an appointment with a doctor via telehealth, because there was no doctor at the hospital. And people were shocked by that. I wasn't shocked by it because I've known for years, and since going through this with my dad, that there are brand new hospitals out in the West that don't have permanent doctors. They have no patients, some of them. There's a saying that's now going around my dad's hometown of Cobar. Whilst there are some excellent staff at the hospital, some excellent nurses, they're saying it's the hospital with no patients, because people aren't allowed to stay there for very long. And we've heard at this inquiry, those frontline staff in many country hospitals out west are without basic tools and equipment, suturing kits, blood, antibiotics. There was my father's neighbour in Cobar who had toes amputated because he wasn't given antibiotics in a timely fashion, was chatting to me the other day, and he said, I don't want to speak up about the care we don't have anymore because I'm frightened. He said, my family have to go back to that hospital. And he said, you know, you and Liz Hayes lost your dads. He said, I only lost my toes. I can live without them. So that pulls at my heartstrings, because it tells me that people out in the bush are content with getting second best. And I feel, Mr. Secord, in a very privileged position because I grew up in that little town. I moved to the city where I can walk into any big, busy public hospital, and although the staff are run off their feet, I get the basic health care I need, and I get it in a timely way. My friends and relatives still living in the country don't get that.
Ms. Hayes, how do you feel when people say that there's a two-tier system and country people should move to the city if they want to get proper treatment?
Oh, I understand it. I hear that a lot. I hear other doctors say it from regions in rural areas. I feel like we've let our country families down. I feel there are second-class Australian citizens when it comes to health. Now, none of us wanted that. None of us intended that. Nobody wants to hear that. But that's what's happened. That's where we are. And the committee must know that by now. You've heard so many stories. You've heard as many as we have. And it's not about beating someone up here, although you do feel like you have to do that sometimes. It is about saying loudly, all of us, this is not good enough. And country people don't expect the open heart surgery unit to land at their doorstep. They just want really basic good care. And I think we all agree on that. I don't think there's a member of the committee who would disagree with that. What I'm saying is that that's where we've arrived. You can't afford to live in the country. People make decisions about living in the country because of health or lack of it.
Thank you, Ms. Hayes, and thank you, Ms. Wells. My time has expired. Thank you.
Thank you.
Thank you. We'll move to the crossbench now. The Deputy Chair, the Honourable Emma Hurst.
Thank you, Chair, and thank you both for coming today and for sharing your story. And I'm very sorry to hear about your experiences as well. I just wanted to ask Ms. Hayes, we've talked a little bit about the fear of people coming forward, and in your submission you also talk about whistleblowers who have experienced threats and warnings for coming forward. Where are these threats and warnings coming from? How is this sort of happening in play?
Well, how it's landing on my doorstep is when I ask doctors and health professionals generally to speak up, and without exception, every one of them is nervous, and every one of them says that there will be reprisals. Now, the reprisals come in the form, when I ask who and how, come in the form of you will be perceived as a troublemaker, you're bringing trouble to the town, you're causing bureaucrats difficulty, you're saying management's not good. That's how the perception will be, and therefore you will not be re-signed. Your contracts will not be re-signed. You will suffer, and therefore your patients ultimately suffer. And that's the balancing act of a lot of medical practitioners in particular. It's that balancing act. Can I afford to cause trouble, if you like? Because if I'm sent out, that's a whole lot of other patients who haven't got a doctor again, or a specialist even. So it comes in the form of from up above. And I know I mentioned this to Brad Hazzard, the health minister. He said he didn't believe that was true. I can tell you it is true. They are very much of the opinion that they cannot rock the boat. And this isn't just recent times. This is for a long time now.
Mm-hmm. Ms. Wells, you mentioned that with your own experience, that you were really trying to investigate exactly what happened, but you were still struggling to even find answers, even though you had this background as a journalist. Is this? I mean, you talked a little bit before about transparency, but can you talk a little bit about how this system is failing to provide people answers when things do go wrong? I mean, what's actually, in your experience, what do you think is happening there?
Well, I think there's a culture of cover-up, and I think my own experience was that I was charged $600 for medical records for my dad, who was a pensioner, and they were my dad's property. They were family property. The fee should have been around $30, and that fee would stop most people from getting their loved ones' medical records. Key documents are missing from those records, a blood checklist, surgeons' reports have inadequate information. There are wrong names on those medical records. So I think most people would not even have the nous to do that. They'd go $600, I can't afford that. There was a ministerial review of experiences at Dubbo Hospital that the minister called for after media reports about my dad and other patients. And the health service had a team go and visit various hospitals, and a meeting was scheduled with me 1 working day before they were to report back to the minister. And at that meeting, I said to them, "Are you serious? You've got 1 working day to take my feedback and give it to the minister." And they said, "Yes, we will extend the deadline because you're giving very good information and it's very serious." And then I got an email from the Western Area Health Service from an executive a couple of weeks later saying, "Well, we actually couldn't fit your feedback into the report for the minister." So I had to call on the minister to intervene, which he did. I wrote to him and he responded to my request. So that gave me not a lot of confidence that the Area Health Service is willing to seriously take the feedback on board and make real changes and incorporate patients' and families' feedback in those changes. My feeling is that every time there's a negative story or a patient speaks up about something that has gone wrong, there's a whole lot of good publicity that goes out to try and sort of cover it up. Well, that's all very well, but it's not changing things. This is just a cycle that continues. I also got a report back from the Clinical Excellence Commission on that review that the minister had ordered. There were errors in that report, which doesn't give me a lot of confidence in the review process. So to answer your question, I'm still looking for answers about what happened to Dad. It's as if no one wants to take ownership for some of the things that happened to him when he was in hospital.
Thank you both. My time has expired.
Thank you very much. Kate Fairman.
Thanks, Chair, and thank you both for appearing today. I just wanted to continue that line of questioning, actually, and we don't have much time to ask questions of you, unfortunately, as well. But so what you're saying, Ms. Wells, is essentially that there's something within the health bureaucracy that instead of looking for ways to find solutions and improve the health system is trying to almost, I think you used the word cover up, but trying to cover up the extent of the crisis in our rural health system. Is that what you're saying today?
Yes, that has been my personal experience, and I'll give you an example. The Western Area Health Service, every time a complaint or an issue is highlighted, will put out a patient survey and they'll say 90%. That's not an exact figure, but they'll say most people surveyed are happy with our service. Now, I was in Dubbo-based hospital when one of those surveys was conducted. A trainee nurse came to the ward with an iPad and looked at my critically ill father and said, "Can you answer these questions? Are you happy with the care, with the food?" And of course, a frail old person who's critically unwell in a hospital is going to say, yes, yes, yes. They're too scared to say no, but because they're worried about what will happen to them in the hospital. And our confidence was so low in the care our father was getting. We virtually slept at the hospital around the clock. We made sure a family member was staying with him because we had concerns about some of the care. Some was good and some staff tried very hard. I acknowledge that and I do thank them again. But yes, a lot of it was very inadequate.
Can I just jump in with another question on this? Are you both aware of the New South Wales Rural Health Plan towards 2021? So this is a state government plan that when the previous health minister this was in, I think, 2014, 2015, basically this plan to have this amazing health system by 2021 says in the introduction by the minister at the time, Gillian Skinner, rural health is a priority for the New South Wales government. We want to make sure people in rural areas can access the right care in the right place at the right time. How do you think they're going with their plan? I'll go to you, Ms. Hayes. Do you think their plan is a success?
Oh, I think it's obvious that the reason you're here, the committee is here, is because there's a belief it is not a success. It is absolutely not a success. If anything, I think the evidence would show from at least the investigations Jamel and I have done, it's deteriorated. Rural health deteriorated. We have hospitals without doctors. Virtual doctors are okay in some cases, but that's the situation we're in now.
Yes, and just on this as well, because like underpinning the whole health strategy, which was launched in 2011 and said we're going to do, basically the government was saying they're going to reform the health system in 2011. There's 4 strategies underpinning it, and the 4 are workforce, research and innovation, e-health and infrastructure, but the only strategy that doesn't mention investment is workforce. Do you think that that is a key reason why we are seeing such a decline in rural health? Is that the government hasn't invested in the workforce? Is that what's going on?
I think that is part of the problem, and part of the problem is, and we've spoken to many doctors about this and medical professionals, is that everyone wants to go to the city. And those who stay in the country, they don't have resources. They're not backed up. They don't have staff. Locums fly in and out. There's no connection with the local people. So it does require staff. And Lord knows there are so many, staff there, but they're all in the city. But it's about getting staff, yes, and getting staff to be prepared to invest in a country town.
Ms. Furman, can I just jump in there? As one of the nurses has previously told the inquiry, bricks and mortar doesn't save lives. It's people who do that.
Thank you. My time's expired. Thank you both so much.
Thank you, Ms. Fairman. We'll move now to a government member. Would that be Honourable Wes Fang or?
Yes.
Honourable Wes Fang.
Thank you very much, Chair, and Ms. Wells, Ms. Hayes, thank you very much for making yourselves available today. And I note that throughout our hearings, particularly across rural, regional New South Wales, you've been there predominantly at the hearings, and I think that's really valuable and important that you've seen the process and you've engaged at all stages. So thank you very much for that engagement. Ms. Wells, I'll start with you. I was listening to your testimony to the other members, and you talked about some of the reports that have happened post the incidents that you've described. And you talked about some errors in the report. I think it was from the Clinical Excellence Commission. Is that correct?
That's right, yes.
Are you able to sort of just expand on sort of what errors were in the report?
There was an incorrect surgery written in the report. Some of the dates were incorrect in the report, and there was conflicting evidence in the report about who actually performed a surgery. So I wrote back to the Clinical Excellence Commission to be fair and pointed those errors out, and they addressed them and sent the report back to me. But my confidence in the reporting process was knocked out from under me from the get-go when Dubbo Base sought to exclude my feedback from Minister Hazzard's review into some of the issues at the hospital. That gave me no confidence, and I was being very defensive after that because I thought, why can't I speak up? My dad was 85, but he was a good man and he paid taxes, and he was as good as the other people whose families have been allowed to speak as part of the review.
Thank you very much for that. So the errors that you've identified, were they corrected in the report, in the subsequent report that's been released? Is that correct?
As I mentioned, yes, the Excellence Commission, Clinical Excellence Commission got back to me, but only after I wrote to them again.
Is there the opportunity for feedback with those people that are actually doing the investigation? Like, do you have the opportunity to meet with them and to discuss the issues? How does that process work?
Yes, you do. And I had a lot of confidence in that because I was contacted by one of the review panel, a doctor from Orange Base Hospital, who phoned me one afternoon at home and said, "We're investigating what happened to your dad. Would you like to come to a meeting and tell us what happened and give your point of view?" So I was filled with a lot of confidence and I turned up for the meeting. It was on a Thursday afternoon. And I gave my feedback at the meeting. I had a timeline of things that had happened to my dad. I had all the medical records. I had a long list of issues and unexplained things in the medical records. I was given a good hearing by that committee. There were two people. There was another doctor from a hospital in Sydney. And as I mentioned, they said to me at the end of my feedback, "This is very serious and we are going to ask for the minister's review to be extended so we can look into what you've given us very thoroughly and provide you with a full explanation of what happened." I then was gutted about a week later, Mr. Fang, when I received an email from an executive at Dubbo Base saying, "Well, your feedback missed the deadline. We couldn't include your feedback in the minister's review." And that's why, Mr. Fang, I wrote to Minister Hazzard and brought it to his attention, and then he did the right thing. He intervened and had that feedback included as part of his review. But as I mentioned, that gave me no confidence in the review process from the start. And remember, I'm a journalist with over 30 years experience, so I don't give up very easily on researching things and getting the right answers. Most people would not do that. Most people would take that as a real kick in the guts and just walk away and say, "Oh, no one really cares what happens, so I'm going to stop there." Remember, country people are sometimes not good about speaking up and complaining or just highlighting things that are wrong. And, you know, my dad was one of those people. He was very stoic and very brave. They sort of take it on the chin. But I think it's wrong what has happened to my dad and a lot of other people, so I'm not prepared to do that.
And I admire your determination. I think it's in fact, I found that country people are usually very determined, I lost my father as well, so I can certainly share the pain that you feel. In that instance, then, that given that you've got no confidence in the Clinical Excellence Commission's investigations, have you had the opportunity to, I guess, close that loop and feed back to them that you haven't got the confidence and what you think might be things that they could actually do better into the future to not only look at the investigations, but also give the family confidence that the situation's being looked at through the proper lens?
Well, I have provided feedback in the letter to them, pointing out the errors in their review. As you can appreciate, sitting through what's happened to a loved one at meetings with review panels over and over, it's traumatic. There's not a day that goes by when I don't think about what happened to my dad, and I'm sure Liz does the same with her father. So sitting through that over and over is reliving that. I've done a lot of that already. I'm prepared to give them more feedback. At the moment, I'm still dealing with the hundreds and thousands of letters and emails and phone calls and messages that Liz and I are receiving after coming forward. And to me, trying to get the voices of some of those people out there is very important. So there are only 24 hours in one day, but I am prepared to do more of that in the future, Mr. Fang. Yes.
Thank you very much. And I really do appreciate your evidence. I'll just pass to my colleague, Mr. Khan.
Ms. Wells, I'm wondering if you have any comments with regards to whether the structure of the Clinical Excellence Commission could be in some way strengthened and made more transparent.
Look, I don't know how to answer that, Mr. Khan. My only experience of the Clinical Excellence Commission was to sit through that review process, to be called up on a Thursday afternoon by a panel to pour my heart out and relive everything that happened to my dad at 2 hospitals and put my trust in that panel to take what I'd said to them, back to the minister and included as part of a review, and then to have that trust betrayed in an email from the base hospital saying that I had missed the deadline. I might add that that review process was recorded with the consent of both parties. So I have word for word what was said and the promise that was made to me that my feedback would be included and that the deadline would be extended. So I don't really know how to answer that. I've not studied the structure of the Clinical Excellence Commission in great detail. Perhaps it would be having more independent people come in on the review process. I met with a doctor from Orange Hospital, which is in the same area, and a doctor from a Sydney hospital. And apparently there was a third person as part of that review panel from Dubbo Hospital who I've never met and never spoken to. So whether it is that outside people come in and do those reviews, that may be something. I'm not sure how to better answer your question.
I'm not. I was looking for guidance as opposed to anything else. In terms of that, the correspondence that you've referred to backwards and forwards, would you be prepared to provide copies of that correspondence to the committee? I would suggest it would be published, but for the purposes of just getting some further background, noting our shortage of time.
I'm happy to provide some of the letters that went back and forward to the committee. The documents are confidential. The review is confidential, so I'd need to talk to other family members. I think the significant point is the letters that went back and forward. And remember too that doing all of this is exhausting. I've been letter writing for nearly 2 years, and these letters have been going back and forward. And some of the letters I get back from Dubbo Base Hospital, the information changes every time I get a letter back. So just when I think I've got an answer to something, it will change in the next letter, which makes me think, what is really the truth here? I think what grieving families and staff who are overworked want in these reviews is honesty and transparency, and they want to have confidence that the review will be transparent and will honour what it says it will do.
Thank you.
Thank you to you both.
Thank you, the Honourable Trevor Khan. Well, to both of you once again, on behalf of the committee, can I thank you very much for participating in the public hearing today. As I said earlier, the advocacy by both of you did play an important role in bringing this important inquiry about. It's our clear intention to produce a report with recommendations that will assist in bringing about the much needed improvement of health services and health outcomes for the citizens of regional, rural and remote New South Wales. And once again, on behalf of the committee, I'd like to thank you both very much. Thank you.
Thank you very much.
That brings us to the conclusion of our first set of witnesses. So we've got a transition now over to our next set of witnesses, and our committee secretary will facilitate that. So whilst that's being done, there'll be just a short break, but people should stay on the video, and we'll be back as soon as we possibly can.
Through your chair, the next witnesses have arrived in the lobby. Are you okay for me to admit them to the meeting and check their sound?
Thank you very much, Andrew.
Thank you. Good morning, Ms. Miles. Good morning, everyone. It's Andrew here from the Secretariat. Can you all hear me?
Yes, we can.
Can you all just speak so I can hear that so that I can hear you?
Yes, I can hear you.
Yep, Leo Bianchi here.
Thank you. And Mr. Beaton?
Yes, I can hear you.
Excellent. I can hear you all loud and clear. We are live and we'll be proceeding in a moment. Please have your oath or affirmation cards ready. Thank you. You can now mute your microphones until prompted.
Well, we'll continue now with our next set of witnesses, and I welcome those witnesses. I will go through each one of you and get you in the order that I provide to state your name your position title and swear either an oath or affirmation, whichever you prefer, the words of which you should have copies of. I'll then, once that's all been done, invite each to make an opening statement, but we'll do, first of all, the formalities. Could we start, please, with Mr. Beaton?
Yes,
Scott Beaton. Thank you, Mr. Beaton.
Scott Beaton. I'm the Vice President of the Australian Paramedics Association, New South Wales.
Thank you very much, Mr. Beaton. Would you swear either an oath or an affirmation, please?
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Can I move next now to your colleague, Ms. Bonacci? You're probably on mute, so just unmute if you could, please. Ms. Bianchi.
Thank you. My name is Liu Bianchi, and I'll be reading an affirmation.
Thank you.
There seems to be a bit of a delay. Is anyone else experiencing a delayed conversation?
Sometimes that is depending on where you are. We'll see if we can improve that. But in the meantime, if you'd be good enough just to, you've stated your name, just your title, and swear either or swear the affirmation.
So my name is Liu Bianchi, and I'm a paramedic for New South Wales Ambulance and an executive member of the Australian Paramedics Association of New South Wales.
Thank you. And could you take the affirmation, please?
I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Could I now move on to Mr. Lovett, please?
Good morning. My name is Ryan Lovett. I'm the chair of the Australasian College of Paramedicine. And I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me should be the truth, the whole truth, and nothing but the truth.
Thank you very much. And Ms. Miles, please.
Hi, I'm Aleka Miles. I'm the chair of the Rural, Remote and Community Paramedicine SIG at the Australasian College of Paramedicine, and I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Well, thank you very much. And can I once again thank our four witnesses in this panel for making yourselves available. We appreciate that. We know that you're all very busy. Can I acknowledge that with respect to the Australian Paramedics Association New South Wales, you've made a submission to the inquiry that's been received, processed, and stands as evidence of inquiry, and that is submission number 664. And with respect to the Australasian College of Paramedics, equally a submission been received, processed, and stands as submission number 275 to this inquiry. All members have had the opportunity to study those submissions, and you can take them as read. I'll invite now for opening statements, and the most efficient way, if it's agreeable, is to have just one from the Australian Paramedics Association and one from the Australasian College of Paramedicine. If in fact there was a desire for all of you to make an opening statement, that is okay, but we'll invite you to keep it a little bit shorter so we can get through the four of them, which would then open up the maximum questioning time for the committee members. So are people happy that I proceed on that basis? Well, thank you. So turning first of all to the Australian Paramedics Association New South Wales, could I invite an opening statement? And I presume Mr. Beaton, you'll be making that?
That's correct.
Thank you. If you please proceed.
Good morning, and thank you for the opportunity to appear on behalf of the Australian Paramedics Association New South Wales members. My colleague and I have a combined ambulance experience of over 40 years. We have both worked in metropolitan and regional New South Wales, and both of us are intensive care paramedics. This means we have extra skills and medications compared to the general practice paramedic. In my time as a paramedic, I have seen the New South Wales health system let down patients, let down communities, and let down the paramedic workforce on countless occasions. I hope today that I can shed some light on some of the issues that exist on the front line. The ICP skill set is invaluable in regional and rural communities to provide the highest level of pre-hospital care available. In New South Wales, over 80% of ICPs are in metropolitan areas. The recent announcement of 203 ICPs over 4 years for regional areas is a great start. However, with almost 200 stations across New South Wales, this is not a large enough increase. Our fear is also that the vast majority of these new ICPs will go to larger coastal centres and not to the smaller communities. It is in these environments that our skills, such as intubation and advanced pain relief, are desperately needed. The lack of funding for ICP positions for remote communities has been a detriment to paramedic wellbeing. Currently, any paramedic who wishes to become an ICP must move from regional to Sydney for 2 years before having to reapply for a position back in regional. They are effectively having to choose between their career and their family and community. While the latest announcement is heartening, we are scared that paramedics will still be asked to relocate. Not having sufficient advancement opportunities in remote communities tends to result in high turnover of staff, which impacts both station morale and the trust built up between paramedics and the community. All ICPs have been trained in new skills equipment as a part of COVID-19 funding. However, those isolated ICPs in rural communities without new specialty equipment vehicles are not being able to apply these life-saving skills as the equipment is not supplied to them. Metropolitan stations and large regional towns such as Orange all received new vehicles and equipment in the most recent rollout, but rural communities continue to miss out. Two of the most vital pieces of equipment have a combined cost of less than $2,000. What does this say? That rural communities are not even worth $2,000 spending increase. I also wanted to touch on the broader issues facing regional paramedic work. I have never seen my colleagues, and I myself have never been so exhausted. We spend a lot of our time acting as a taxi service for New South Wales Health. This is not to say that patients do not need to be transported. They absolutely need to be in the right healthcare facility for their injury or illness. But much of the time, we are transporting patients who do not require our level of clinical care. When we transport these patients, we are taking the only resource away from a small community. For example, I frequently undertake transport that take 5 hours overnight. I once undertook a transfer that took 3 days. When I'm on these transfers, there is no one on duty or on call in my community. If someone has a heart attack, they have to hope that there's an off-duty paramedic who is available and fit for work. There are only 5 paramedics who work in my station, and with 2 of them out of town, your chances are slim. There's a solution ready-made for this: our non-emergency patient transport vehicles and patient transport officers. They do amazing and vital work, but they are not a 24/7 service, and they generally only service major regional centres. One of the biggest contributors to our workload is the lack of mental health facilities in regional areas. This is one of my biggest areas of concern for our patients as well. Right now, at many stations across Western New South Wales, closest declared mental health facility is 2 or 3 hours away. For example, Lake Kajalico goes to Griffith for mental health patients. This takes a patient away from their support network, increasing their anxiety and often exacerbating their condition. Thank you again for your time today. I hope to be able to shed light on the issues that are impacting paramedics and patients alike in regional communities. We are really hurting badly. I look forward to sharing my experience with you and contributing to this important inquiry.
Thank you very much, Mr. Beaton. That's a very good opening statement, very clear and very precise. Can I move now to the Australasian College of Paramedicine? And I was wondering, was it the intention that one or both of you would be making an opening statement?
No, sir, I'll make that statement on behalf of the college.
Thank you very much, Mr. Lovett. Could you please proceed?
Thank you, and thank you to the committee for the opportunity for the college to present to you today. The college is the peak professional association supporting and representing over 10,000 paramedics and paramedic students across Australia and New Zealand. Our purpose is to advance excellence in paramedicine and out-of-hospital patient-centred care across Australia. So the key question at hand, this is whether health outcomes and access to hospital services in regional, remote and New South Wales is appropriate, adequate and on par with metropolitan centres. The answer is clearly no. Demographically, we know that regional, rural and remote populations in New South Wales are older, poorer and suffer a greater burden of ill health and lack the access to quality and consistent healthcare, with a patient experience well below what's available in metropolitan areas. As you've heard from my colleague, Mr. Beaton, rural paramedics attend to a wide variety of patient presentations, from critical traumatic injuries to chronic complex geriatric syndromes in aged care facilities. They respond to mental health illnesses, substance abuse, and they're often there during the final days of a person's life, providing palliative and end-of-life presentations. Most of these attendances have traditionally fallen within the domain of primary and preventative care. However, due to the prolonged shortages of rural doctors and limited availability of community nursing, patients are increasingly being managed by the paramedic workforce in these areas. This is exacerbated by the lack of options for out-of-hours care and the geographical distribution of health services. And communities are increasingly relying on paramedics in the delivery of routine health care, particularly when that primary healthcare services are difficult to access or not available at all. College is here today proposing the utilisation of community paramedicine, supported with a scope of practice focused on providing holistic, evidence-informed primary and preventative health care, in addition to our traditional role of urgent and emergent care. Community paramedics could be employed in the community by ambulance services, by local health districts, by private health clinics, all contributing and supporting the activities of other health professionals in delivering quality patient-centred care. We propose that community paramedics will work as part of a multidisciplinary team, delivering team-based care in partnership with general practitioners, specialists, community nurses, hospitals and local health districts. There are increasing numbers of successful national and international community paramedic programs that highlight the valuable role that paramedics can play in multidisciplinary team-based healthcare. Importantly, whilst other healthcare professionals are struggling with a shortage of graduates and staff, paramedics, as a recently registered health profession, have a glut of graduates who are unable to find work with the ambulance services, with the jurisdictional ambulance services. With a small additional education, generally a graduate certificate or graduate diploma, building on the extensive tertiary education that paramedics currently receive, community paramedics would be ideally placed to work in regional, rural and remote communities, playing a vital role in filling the primary healthcare gap. We thank again the committee for the opportunity to present and look forward to discussing this recommendation with you.
Thank you, Mr. Lovett, and that was a very good opening statement and adds very nicely to the very valuable submission that's been made by the organisation. So thank you. We'll now move on to
Mr. Donnelly.
Yes.
Sorry, I also would like to have an opening statement. My opening statement is a little bit different to my colleagues. So would I be able to proceed?
Yes. Could you let me know how long you intended to speak for? Because
2 minutes.
Yes, no, thank you for that.
Go.
Please proceed.
Thank you. So I've been a paramedic now for 25 years. I'm a qualified intensive care paramedic, an extended care paramedic, and I'm also a registered nurse. I work in the regional town of Tuncurry on the mid-north coast of New South Wales. So I'd like to explain to you what ECPs are, extended care paramedics. We undergo specialist training in low acuity pathways. So what Ryan was talking about, community paramedics, we are a subsidiary of basically that. We focus on treating patients in the community and we refer them on to non-emergency department pathways. The ECP scope of practice is at the opposite end of the acuity spectrum to ICPs, where ICPs are high acuity, ECPs tend to be low acuity. We have the potential to be extremely effective if we're sent to the right patients. So generally in the city, there are about 83 funded positions in Metro Sydney for ECPs, but there are no funded positions for ECPs in regional areas beyond Wollongong and Newcastle. So the main role of ECP centres on the recognition and management of minor illnesses and minor injury. So we do things such as suturing, initial wound management. We reduce shoulders, patellas, toes, fingers, and then refer people to GPs. We do back slabs and plaster, as well as fiberglass for suspected limb injuries and fractures. We replace urinary catheters and gastrostomy feeding tubes. We also do a lot of antibiotic treatment for skin conditions and for community-acquired pneumonias. So you can see that our range is quite huge. As an ECP in a regional area, I operate on a dual ambulance, meaning I don't operate on my own. So it is a real ad hoc opportunity to attend to patients to prevent hospitalisations and presentations to EDs. So, for instance, I've sutured so many patients already at Tungurry, and I've put on back slabs and I've reduced shoulders. And those patients I've referred directly to their GP and avoided an ED. But I'm the only one in my area. So I just wanted to talk about quickly is the major barrier that I see with New South Wales Ambulance is sending the right paramedic to the right patient. And that is one of the biggest issues that we have, is that once that 000 call comes in, the KPI of getting an ambulance, any ambulance, onto a case takes precedence over a KPI that focuses on getting the right patient serviced by the right paramedic. And we'd like to expand on that further if you are so way inclined. So that's what I wanted to explain, is that role of ECPs and ICPs and how effective we can be in regional areas. Thank you.
That was very good, Ms. Bianchi, and it's very helpful to provide that level of detail on the two categories. And I'm sure that's going to lead to some questions from some of the members, so thank you. So we'll move to questioning. Can I just remind committee members that we've got through till 10:55, then we need to move to the next group of witnesses. So to be fair to the next group, we'll keep it on time. So the time between now and then will be divided equally between government, crossbench government and opposition in equal amounts. So we'll commence with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair. My first question is actually to Mr. Beaton. Mr. Beaton, you made the extraordinary claim of a three-day transfer. What the hell? Why would you have an ambulance and paramedics on a 3-day job? Wouldn't it have been better to fly them or do something different? Can you explain the detail of that?
Thank you. That transfer was a patient that went from Broken Hill to Royal Adelaide and required a specialist ambulance, a bariatric ambulance. So it required us to leave our local town of Gilgandra because my partner and myself working at the time, we were the only two qualified people in the area for the bariatric ambulance. We had to pick it up from Wellington, then drive to Broken Hill, take the patient from Broken Hill to Adelaide, and then of course we had to get back from Broken Hill back to Gilgandra. I believe there was an issue with aircraft at the time that weren't available to be able to transport that patient, so therefore they had to go by road.
So Mr. Beaton, could you just explain what a bariatric ambulance is, please, for the committee?
Bariatric ambulance, we have a number of them. The ambulance service has a number of them across the state. They are to take your larger patients, those that won't fit into a normal ambulance due to a larger stretcher, a lot of equipment in there and able to take the larger patients. So that's basically what bariatric is.
Thank you very much.
So Mr. Beaton, what did the community of Gilgandra do for those 3 days? Were there other paramedics around, or what was the situation?
I believe they had to try and fill the shifts on overtime, and at the time there weren't a lot of paramedics doing overtime. They were able to fill one of the shifts for the full 3.5 days. and they relied on some off-duty paramedics to respond to other jobs. So they are off-duty paramedics are just paramedics who, in their 6 days off, we do 8 days on, 6 days off in our town. So they're relying on people on their days off and rest and relaxation to respond to jobs.
Now, Ms. Biaggi, you were nodding during Mr. Beaton's evidence. Why were you nodding? Do you have examples that you could share with the committee?
Yeah, absolutely. So quite often in Sydney, when I was an intensive care paramedic at Blacktown, I would be the only one available to do these bariatric jobs. And some of these patients have been up to 400 kilos. So that's a really big task. But I would literally be taken off the intensive care vehicle. So there was no intensive care vehicle at all for Blacktown. And I would be sent all over the place to attend to a bariatric patient that might have been at the other end of metropolitan Sydney. I've also been to Lismore and Grafton to take patients to appointments, simply to take a bariatric ambulance from Sydney to these regional areas because they just did not have enough bariatric vehicles around. So pretty distressing to leave your own community to have to do those sorts of transfers. So it's not uncommon.
Mr. Beaton, you made reference to ambulances being a taxi service in rural and regional areas. Can you elaborate on that?
Yes, quite often we're used to transport patients that are not high acuity patients. So if we have to transfer someone from a smaller, remote hospital to a larger centre, they just use an ambulance rather than using other resources such as the patient transport vehicles or even private vehicles in some cases. Probably the most notable is not that long ago, I transferred a patient at 2 o'clock in the morning who had a sore knee and had a sore knee for a week, and they were transferred just for an x-ray. The hospital that they came out of didn't have x-ray, but we drove past 2 other hospitals that would have had x-ray at 8 o'clock in the morning to drive them to the larger town into Dubbo to get an x-ray just for a sore knee that had been injured a week earlier.
Do you find yourself in situations just shaking your head at circumstances like this?
I used to shake my head and I used to get exacerbated by it, but now it's such a common thing that it's just a shrug the shoulders and say, oh yeah, well, this is what we do. It shouldn't be, but that's the way we get to now.
But don't you feel that that puts lives at risk because an ambulance is engaged in other activity and it's actually a diversion of scarce resources?
Absolutely. It does scare me because if someone is in desperate need of an ambulance in my town or in any other town around where there's no ambulance available, I don't know how they're going to be attended. Like if my elderly mother lives in this town and I worry that there is no ambulance available for her if I'm driving hundreds of kilometres to transport patients that probably could be going in lower acuity transport vehicles.
So what do you do when you have a situation? Do you find that you have to do what's like a Sophie's choice? You have to make a decision. Do we go for this patient or do we go to that? What do you find yourself in situations like that?
I don't get the choice to make that decision. That's made by ambulance in the dispatch. The dispatchers are then there's the extra stress that goes on to them having to find an ambulance. If a cardiac arrest or some serious job comes into your town, they're fully aware that they have no ambulance resource in that town other than trying to find off duties. I myself probably get called a minimum of once in my 6 days off to attend off duty call outs because the crew are unavailable, either on another job or on a transfer.
And you can't say no, can you?
I can say no to off duties, but I can't say no when I'm on duty at all. If I'm unavailable because I've had a beer or if I'm not in town or looking after my kids for homeschooling at this point in time, then I can't go and do the job when I have family commitments. But probably 80% of the time I go and do the off-duty jobs.
Now, I'd like to ask a question to to Ryan from the college. Do you find that because of scarce resources in rural and regional areas that paramedics are called to engage in medical procedures and do activity beyond their scope of practice?
So I think paramedics, the education that's provided to paramedics nowadays gives them a really good grounding for how and when and kind of the manner in which they should practice. So it's generally, I wouldn't say they generally are practicing outside their scope. And to kind of extend on what Louis said, it's when we go to paramedics, when we go to these patients who, it might be an 80-year-old person, lots of chronic conditions, lots of medications, and paramedics traditionally who have been trained in emergency and urgent care, they've been trained in how to respond to a cardiac arrest, and they've got that educational background. When they find this person that's got all these things wrong, they're trying to work out how the various medications work together. That's not traditionally the education that's been provided to them as part of their undergraduate degree. And so a lot of paramedics, and we take our hat off to them and we support them as part of the college, have gone out and acquired this education independently. They've gone out and undertaken graduate certificates, graduate diplomas to give them this breadth of understanding. And paramedics, I think the education we do give them, it's a really great solid foundation. And unlike some of the other professions, they've got this great foundation and we can build on that foundation. As Louis said, you can build on this foundation with extended care paramedic education. You can build on this foundation with intensive care paramedic training. So I think that's why paramedics are really well positioned. We can give them additional education, additional training, give them that exposure to that extra scope and those extra patient presentations, and we can really kind of fill that gap.
Mr. Beaton, back to the situation that you highlighted in Gilgandra. So what would be the recommendation or the remedy for the situation? Is it more ambulances? Is it more paramedics? Better coordination? What is the response to what you've highlighted that occurs in your community?
I think it's exactly what Liu talked about earlier, was the getting the right ambulance to the right job. So whether a better system in regards to triaging the call, in regards to do we actually need 2 registered paramedics to transport this patient from one hospital to another, and in a number of cases we will. There can be critically ill patients, but there's a lot of these unnecessary transfers that could free up the paramedics to still be available in the town. If you ask the question of do we need more paramedics, the answer is yes, but how many paramedics do we need to make sure that there's always an ambulance available is one of those questions of how long is a piece of string. So especially in regional and rural areas, in your larger centres, your Dubbos, etc., more ambulances would of course assist the community. In Dubbo, they're constantly doing transfers to Orange Base Hospital because there's a higher acuity care at Orange. So you lose an ambulance for 4 hours out of Dubbo. Do you put another ambulance on in Dubbo? How many more transfers are they going to keep putting on to do that? It's never ending. The more ambulances you put on, there's probably more transfers. So there needs to be a better system of triaging to find out what ambulance resource is best suited to transporting this patient.
Thank you, Mr. Beaton. We'll need to move across to the crossbench now for their questions. So, Deputy Alderman Hurst.
Thank you, Chair, and thank you all for coming today. I have a question for Ms. Bianchi. You mentioned in your opening statement that the ambulance itself is prioritised over getting the right paramedic there. Can you explain to us what you mean by that, and also how we fix it, what needs to actually change?
So the KPIs are obviously a reporting tool that New South Wales Ambulance use for New South Wales Health. But what they have is a KPI that emphasises the 000 call and the time that it takes to place an ambulance, any ambulance, on that 000 call. So what that does, it means that you're not putting the right ambulance on the right case, because your KPI is directed at putting an ambulance on that call. Even if that ambulance is in Tungurry, and the job is in Port Macquarie, it doesn't matter because the KPI supersedes every other need because you've put somebody on the job, regardless of where it is in the state. So it's quite often you get a job and the closest car is hundreds of kilometres away, but you've put a car on it. Do you understand what I'm saying there? So the flow-on effect is that you then have this ripple effect of ECPs attending high acuity jobs needing backup, and then you get P1s and ICPs attending really low acuity jobs that are ECP, but then have to transport them because they cannot fix that low acuity case. So then you get all this ramping at hospitals and presentations at hospitals that don't need to be there. So the ECPs are backlogged looking after patients and waiting for a backup car, and you've got the ICPs transporting a patient and waiting at the hospital to offload. Do you do you understand that flow-on effect just from that one KPI? It's a disaster. So if I was to say to you, instead, if we looked at a KPI that looked at putting the right ambulance on the right job, you look at somewhere like the Great Lakes, area, Manning Valley, you've got 45% of the population over the age of 55. That's predicted in 21, right? Let's look at the type of paramedic skill sets that you can put in that community. Let's put skill sets that would really facilitate those communities in geriatric care, falls, catheter care, wound care. They're the sorts of paramedics we should be looking at potentially, or even the higher end ICPs, because there's so many cardiac conditions in that older population.
So it's really about sort of stepping back and having a look at where the experts are needed, but that sort of hasn't happened. And is that sort of a funding issue, a lack of paramedics in the right spaces, and not enough in rural areas? Is it all just coming back to those same issues? And this is just another symptom of that issue.
Agreed. The ambulance service, to my knowledge, has never placed paramedics really about their skill set other than looking at the number of jobs and the acuity of job and deciding where they might put their intensive care paramedics. You know, that's as good as that's as sophisticated as it's got. And we need to think a lot smarter, not just more paramedics, but let's look at the skill set that we have.
Wonderful, thank you. I've just got a very quick question. I know I don't have much more time left for Mr. Lovett or Ms. Miles. What could the government do to really foster the growth of community paramedics in rural and regional areas? What support is needed?
Yeah, I think Louis is exactly right. So you look at some other jurisdictions around the country and they undertake a really detailed community modelling and community profiling program. I know in South Australia, they just completed theirs. It took them about 6 months, but they built, the government built and the health department there built a real profile of every community and said, what do we need to service the health needs of the community, not just the ambulance needs of the community, but holistically, and then developing models of care to suit that community. And that is either, that's either might be a volunteer ambulance response, it might be a paramedic ambulance response, or it might be an extended care or community ambulance response. So it's about understanding the community and really targeting the service needs. And second to that, very quickly, is that many jurisdictions now are focused on the fact that paramedics are owned and operate only in an ambulance service. And I think in 2021, that preconception really needs to be broken. A paramedic is an independent medical practitioner, like a doctor, like a physiotherapist, and they can work. Should be able to work independently. They should be able to work as part of a GP practice, which is what Alaka does. She works as a paramedic embedded in a GP practice, and they should be able to work across the health spectrum to service those community needs.
Thank you.
Kate Pham.
Thanks, Chair. Thank you all for appearing in what is no doubt a busier time than usual for your organisation. So just wanted to go to the APA submission where you talk about the current figures for what cars are needed on the road, and you say that that's based on, it's the minimum operating levels based on 2010 demand figures, so based on demand figures that are 11 years old. Is that still the case? Because your submission, I think, was done in January. I'm just checking whether anything has changed since then. Maybe. Yeah, Mr.
There
Beaton.
wasn't. Yes, there was an Industrial Relations Commission hearing and ruling that that has changed slightly now. The old MOLs, or minimum operating levels, have now moved to a terminology called PAR, which is paramedic agreed rostering. So it's the actual filling of all rosters. So the levels have risen. But it took an Industrial Relations Commission ruling to bring that up, those levels up. There's still probably not enough in some of the metro areas, and probably not enough in a lot of the regional areas as well. But it certainly has improved since that submission was put in early last year or late 2019.
Okay, thank you. This leads into the next question, actually, because your presentations today are clearly full of solutions in some ways to the crisis in regional health for ambulances and what paramedics are experiencing. What's been the government's response, or New South Wales Ambulance's response, to kind of the pleas for change and for reform, and for some of the solutions that both of you have in your submission? I just wanted to, because it's frustrating, to be honest, to hear this, because it's like, well, why isn't some of this happening? I might go to the APA first. Ms. Bianchi, did you want to?
Yeah, I'd like to speak to that. Certainly in the extended care paramedic space, I believe New South Wales Health are absolutely tone deaf about the program. It has really fallen into disrepair. We really are struggling as an extended care paramedic group. The program has fallen onto its knees, and yet on 3 occasions I've presented to the Minister Hazzard that it's really struggling, and yet we still are not able to bring it back up to its former glory. I mean, it's been in practice since 2007, and unfortunately, very little commitment from New South Wales Ambulance and Health has gone into it, and yet it saves New South Wales Health millions and millions of dollars. It is such an amazing program. I cannot speak of it more highly. Our ECPs are critical to the better functioning of regional and metropolitan services. It is amazing what they do. Me alone in Tungurri, as the only ECP, I would probably, if I'm sent to the right case, I would do almost 100% ECP non-emergency department presentations, and that's only one person. So when we look at regional areas, the amount of increase in workload has been exponential. So if we look at even Tungurri and Great Lakes alone, the number of responses in the January-March 2001 year compared to the same time last year, 2020, has gone up 23%. That's the number of responses. Now, our workload is crazy. How can we address all those issues with the amount of staff we have? We can't. We're just chasing our tail all the time. So I think your question is excellent. The New South Wales Health Department need to start listening to our ideas and our solutions, because they are realistic and they can be implemented, just like Ryan said. Other states are doing it. Let's be sophisticated about this.
Thank you. I think it may be time to move to government questions. I'm not sure which member would like to jump in, the Honourable Trevor Khan or the Honourable Wes Feng or Natasha?
It's me.
Honourable Trevor Khan.
Look, I'll just start, and I think it's with you, Mr. Beaton, but I certainly welcome others in terms of making a contribution. And it goes back to this issue of ambulance versus patient transport. Is one of the problems that the ambulance service and patient transport are essentially managed by different parts of the health system? Is that one of the causes of the problem?
I believe that is one of the major issues. So a few years back, I couldn't tell you how many, it'd be more than 10 years, that ambulance actually ran the majority of patient transport. That then moved across to HealthShare. And then out here in regional areas, we have a different group called VCare that manage the patient transport section out in regional areas. What we find is that they will take the bookings from the local hospitals, they try and put patient transport vehicles on them, but when they can't do them, they just push it across to ambulance. And so regularly at 5 o'clock in the afternoon, we get put on a patient transport. Now, we're supposed to finish work at 6 o'clock at night, but we then get tasked to a transport at 5 o'clock. We get home at 8 o'clock in the evening, and there's been no ambulance in Gilgandra for 2.5 to 3 hours while we've been doing a transport, just because patient transport didn't have enough cars or crews to actually get that patient down to Dubbo. And that seems to be a lack of foresight, planning to get the patient transport vehicles around, a lack of patient transport vehicles, and might be part of the issue. I'm not sure. I don't know the inner workings of how patient transport in Western work, but I'm sure there are others that do.
So just before I ask a follow-up question, Ms. Bianchi, you seem to be nodding your head a bit there. Do you want to make a contribution?
Well, I think I'll be honest with you, when we had patient transport underneath the umbrella of New South Wales Ambulance, it was a bit like logistics. You never had a patient transport vehicle going somewhere without being loaded. And I don't mean to represent patients as a parcel, because they're not, absolutely not. But it didn't make sense to be moving people in a patient transport vehicle and then doing a return trip without them being loaded. And the amount of work that they got done because of dispatches from New South Wales Ambulance were able to control the whole picture within the holistic look of what ambulance was doing at the time. Now you might see patient transport vehicles going everywhere unloaded, and it doesn't make any sense. We need to coordinate this. If we're not going to put more of them on, let's make sure that when they're moving patients to and from, that they're making a return journey with at least a patient on board. So there really seems to be a huge inefficiency of the service now. And even the patient transport staff will say, wow, we used to be a lot busier. Well, we're taking the load now as well. So it doesn't make sense. It's crazy.
So this is actually not a follow-up question. No, actually, I'll keep my philosophical question for a bit later. And it relates to the model of an ambulance service, if I describe it that way. But I'll park that to one side. Mr. Beaton, you raised earlier on the issue of the equipment in ambulances in rural areas. I'll separate it out from regional areas, and the lack of some particular items. Are you able to specify what those items are and whether you have an explanation as to why they're not available in those ambulances?
Sure. It's in regards to the intensive care paramedic training that all intensive care paramedics received earlier this year or even late last year in regards to COVID funding. So there's a whole bunch of new skills that they gave us. Yep. There's new equipment. So 2 pieces of equipment that are actually that I mentioned earlier. One is called an EasyIO. It's an intraosseous needle. It's a drill. It's used by helicopter crews. It's a way of getting, instead of using an IV line, if you can't get an intravenous line in standardly, then you essentially, it sounds horrific, put a drill into the bone of someone to administer life-saving fluids or even pain medications, etc. That drill costs, I believe, somewhere around $550, plus its other pieces. For some reason, I have no idea. I've actually personally written an email to Dr. Morgan our commissioner, who said that the funding just wasn't there. There's the other second item is called a video laryngoscope. In order to put an intubation, to assist with intubation of a patient, it's a tool that you use so you can see down the throat when you're placing a tube down into a person's throat to help them breathe. This would not only help me if I need to perform an intubation, but it also assists the hospital because they don't have one either. So if ever they need to intubate someone, I can be called to go and assist them as well for the intubation. So they're the two items. I believe one costs around $550. The other one costs somewhere around about $700 to $800 is my understanding is how much they cost.
Right. Thank you. I think this is to Mr. Lovett and Ms. Bianchi, but of course it's Ms. Miles's area as well. And I want to just come to this issue of the community paramedics. I wonder if you're able to explain to me why, or we can talk it in a more general sense, why this hasn't caught on in New South Wales and why others have looked at the model and apparently seen some suitability in it.
Yep, I'll jump in quickly and I'll defer to my colleagues. So essentially, if we look at community paramedic models, for example, in South Australia, which is the recency of my experience, so the model in South Australia is co-funded between health and the primary health network, and recognition of the fact that they're filling the gap of a general practitioner or primary healthcare in that town. Ambulance service funding models, and this is not peculiar to New South Wales, this is nationally an issue. Ambulance service funding models generally, and this is regulatory, defer to transport. So an ambulance service will receive more funding if they transport a patient to hospital in the order of 4 or 5 times more funding in some places than if they were to manage that patient on scene. You know, it's in the order of a couple of $100 if you go to a scene, manage the patient and leave the patient at scene, that's the funding, or $1,200, $1,500 if you transport them to hospital. So there's a perversity of funding that the investment, there's no incentive to invest in the models that keep people away from transport. And Louis is exactly right. You know, if you look at the total cost of that presentation, not only the ED cost, we know that a patient that presents to ED gets worked up significantly more interventions, more tests. They might get admitted overnight for observation. If we can keep that person out of hospital, the whole health system savings at a state and Commonwealth level can't be underestimated.
Ms. Bianchi, do you want to comment on that? I hoped that was the sort of observation that was coming.
Oh, I mean, the figures speak for themselves. The costings, the savings are incredible. I'm talking about in the 50, to $70 million a year of non-transport to EDs. So I just don't understand how fiscally the New South Wales Health and Ambulance aren't putting more into the program. I mean, whether it looks like or is called a community paramedic, we're actually doing it. We're just not doing it with enough support. So we're doing it ad hocly, which is really such a shame because we should be saving not in tens of millions, but hundreds of millions of dollars. And so from a cost perspective, I just don't understand why they're not supporting it more. And ECPs out there, they just love the role. They absolutely love it because it's so definitive and it's got an endpoint and they actually achieve so much. So listen, I think it is a really big question to be asking Minister Hazzard again and again and again until he starts listening, because he's not listening at the moment.
So sorry, Greg.
No, that's okay. Perhaps that might need to go unnoticed, Honourable Trevor Kung, because we just pressed against. Thank you very much. We're just pressing up against our timeline. On behalf of the committee, can I thank all 4 witnesses? I have to say, the range of questions and the answers that flowed have been very instructive in terms of giving us, I think, some pretty rich insights into the matters of paramedic services and ambulatory services in regional, rural and remote New South Wales, and insights into views and opinions about how they can be enhanced and improved. So the committee thanks all of you very much for not just your submissions, but also your oral evidence today. So thank you. So we'll now move on to the next set of witnesses. And once again, just a brief transition period. Don't leave the hearing. It'll just be a couple of minutes or so, and then we'll be on to our next group. Thank you very much.
Through you, Chair, the next witnesses have arrived in the lobby. Are you okay for me to admit them and check their sound?
Thank you very much, Andrew. That would be great.
Good morning, all. It's Andrew here from the Secretariat. I'll check your sound one by one. Ms. Falkai, can you hear me?
Yes, I can.
Thank you. Mr. Yick, can you hear me?
Yes, I can.
Thank you. Ms. Carter, can you hear me?
Yes, I can.
Thank you. And finally, Ms. Michaels, can you hear me?
Yes, I can.
Excellent. Thank you. We're live and we'll be proceeding in a moment. Please have your oath or affirmation ready. Thank you. You can now mute your microphone until prompted.
Thank you. We'll now proceed with our next set of witnesses, and I'd like to welcome the four of them. For each witness, I'll ask you please to state your name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which should be before you. Once that's been done for the four of you, we will then move to opening statements from the respective organisations, and I understand there's a witness from each who will make the opening statement, and then, if agreed, and I hope you will, we can then progress to questions from the committee members. So that's how we'll proceed between now and 11:40. So may I commence with inviting Ms. Michaels to introduce herself and proceed with the formalities.
Thank you. My name's Kristen Michaels. I'm the Chief Executive of the Society of Hospital Pharmacists of Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Ms. Michaels. Can I now invite Mr. Yick to follow the same?
Thank you. My name is Jerry Yick. I'm the Head of Policy and Advocacy at the Society of Hospital Pharmacists of Australia, and I'm currently a practicing hospital pharmacist as well. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. I can move on then to the Pharmaceutical Society of Australia, and first of all, Ms. Falkai, could I invite you to introduce yourself and follow the formalities?
Thank you. My name is Chelsea Falkai, and I am the New South Wales President of the Pharmaceutical Society of Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And now moving on to Ms. Carter, if you could please proceed.
My name is Karen Carter. I'm an owner of community pharmacy in Gunnedah and Narrabri. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you very much. And on behalf of the committee, can I invite us, could I first of all, I should say, thank both organisations in the first instance for making your submissions. For the Society of Hospital Pharmacists, your submission, as you would be aware, is being received and processed and stands as submission number 627 to this inquiry. And with respect to the Pharmaceutical Society of Australia, equally a very good submission, and it's been received and processed and stands as submission number 250 to this inquiry. So you can take both submissions as having been read by committee members. So in terms of your opening statements, you don't need to repeat anything in particular in your opening statements, but I welcome both organisations to, through one of their witnesses, make an opening statement, and then would it be okay that we proceed to questions? Is that agreeable with our witnesses? We open up the questions? Lovely. Okay, well, thank you. So we'll first of all commence with the Society of Hospital Pharmacists. Who would be giving the opening statement in that case?
That would be me.
Thank you very much. Please proceed. Michaels.
Thank you. So good morning, Chair, Deputy Chair and members of the Portfolio Committee. As I just said earlier, I'm the Chief Executive of the SHPA. We're a membership organisation of some 5,200 hospital pharmacists who work around Australia. We also have hospital pharmacy technicians, hospital pharmacy interns and students who are members of our organisation. In New South Wales in particular, there are over 1,300 hospital pharmacists, according to the Australian Institute of Health and Welfare, and hospital pharmacists account for just over 23% of the entire hospital pharmacy workforce. First of all, I'd like to acknowledge Ms Wells and Ms Hayes, who provided evidence earlier this morning about the tragic deaths of their fathers, where vital preventive medicines for stroke and heart attacks were implicated. Hospital pharmacists are responsible for supply of medicines to all hospital inpatients, outpatients, and upon discharge from hospitals. It's in hospitals where hospital pharmacists treat patients at their most unwell. It's the value of pharmacists to patient care outside of supply, though, that is lesser known. And this lies in their clinical pharmacy activities, such as doing daily reviews of medication charts, detecting and managing drug interactions, and providing counselling to patients and safe transitions of care upon discharge. However, due to chronic underfunding of hospital pharmacy departments and a lack of recognition of clinical pharmacy services, virtually all New South Wales hospitals are not staffed sufficiently. In other states, hospital pharmacists provide medicines at discharge and provide thorough medication counselling when patients are taking new and different medicines. Our New South Wales members report that a large portion of their patients don't get any pharmacist counselling when being discharged on their new medicines and are often handed a bag of medicines by a nurse on their way out of the hospital. These workforce issues are, of course, exacerbated in rural, regional and remote hospitals. And this is inextricably linked to over 20,000 medication-related incidents, which are reported to the New South Wales Clinical Excellence Commission, where hospital pharmacists are unavailable to prevent them. When you look at this on a per capita basis, or when you look at it on a per 100 hospital beds, whether you look at this on a per capita basis, per 100 hospital beds, or per 1,000 admissions annually, New South Wales hospitals comparatively have the smallest portion of hospital pharmacists compared to any other state. Our hospital pharmacist members in New South Wales know their pharmacy departments are the most poorly resourced, and addressing this workforce gap is key to improving the safety and quality of care for New South Wales patients and protecting them from medicine-related harm. Thank you.
Thank you very much, Ms Michaels. That's a very detailed and very prescient opening statement, which adds very nicely to the submission. I'm sure will lead to some questions. Can I move now then to the Pharmaceutical Society of Australia and Ms Felkay, I presume that you're going to give the opening statement?
Yes, thank you, I will.
Thank you. Please proceed.
Good morning to the Portfolio Committee and to my SHPA colleagues. My name is Chelsea Felkay and I am here representing the Pharmaceutical Society of Australia, or PSA, as the New South Wales Branch President, and I am joined here with Karen Carter, who is a Fellow of the PSA and pharmacy owner of Gunnedah and Narrabri pharmacies. The PSA is the National Professional Pharmacy peak body, which represents all Australia's 34,000 pharmacists working in all sectors and across all locations. In March this year, the PSA released their Medicine Safety in Rural and Remote Care document, which has been provided for your reference. The document outlines the specific challenges faced by our rural and remote neighbours, particularly in the areas of medicine and health service access, medicine safety, and pharmacist workforce. Geographical distance to healthcare services such as hospitals and GP clinics make it difficult for patients to access timely care, sometimes resulting in unnecessary hospitalisation. Increased disease burden and potentially preventable hospitalisation in rural and remote Australia are up to 2.4 times that of non-rural Australians and cost the healthcare system on average $400 million. At least 50% of this is preventable. This inequality to access to medicines and health services based on geographical location directly impacts on health incomes of our rural and remote neighbours and should not be tolerated. A number of potential solutions have been identified to decrease this gap in health outcomes due to medicines. Medicines access has been improved since the continued dispensing arrangements were put in place to meet the needs of populations impacted by emergency situations. These examples include when a patient is unable to access more of their medicines and no longer have repeat prescriptions and are unable to access a GP. Medicine safety is a particular risk during transitions of care, as noted by my SHPA colleagues, such as discharge from hospital. Embedding and funding pharmacists across multiple regional and remote practice sites would reduce medication misadventure associated with transitions of care and establish more coordinated and integrated care. Finally, pharmacists are skilled and accessible workforce that could be better utilised. In some communities, they are the only healthcare practitioner. Building rural and remote pharmacist workforce capacities and capability is essential to improve access to life-saving health interventions. My colleague Karen will be able to detail examples of the challenges and solutions as they play out on the ground during the question time. Thank you.
Thank you very much, Ms. Falcai. That's equally a very clear and precise opening statement, which sets up the questions nicely. We'll now proceed with questions. It's about 7 minutes past 11. We go through to around 11:40 or thereabouts, with the time shared equally between opposition, crossbench and government members. So we'll commence with the opposition first, the Honourable Walt Secord.
Thank you, Mr. Chair. In fact, my first question will actually go to Ms. Carter, involving Gunnedah and Narrabri. As Ms. Falcai actually said earlier, that pharmacists actually find themselves in many country areas to be the only healthcare practitioner. Can you give us a bit of an insight into being on the front line, and what should this committee respond and recommend in relation to pharmacists?
So we have a shortage of GPs in our area. So we are a triage service. We often have people presenting with symptoms such as a UTI, and we know what may be the best medication for this treatment, but we are unable to do a counter-prescribing on antibiotics, which in Queensland there is a program going on. Other services, I've actually finished a diploma in wound care from Monash to improve my wound care services in both areas. We have a lot of acute wounds and chronic wounds, and so we do a lot of dressings for that particular area. We also triage people who we know need to go and see doctors. So we have medication review services, and we can identify people with high blood pressure. These people need to see a doctor straight away, but that has difficulty with access. So sometimes if we could have something like collaborative prescribing, we could allow monitoring of people's blood pressure, because they have access to our pharmacies in Gunnedah 7 days a week and in Narrabri 6 days a week. So we do a lot of monitoring of people's blood pressure. And if we had collaborative prescribing, we could then allow dosage increases or decreases for just medications for blood pressure.
Ms. Carter, what do you mean when you say collaborative prescribing? What does that actually mean?
So if a GP was to start someone on a blood pressure tablet of a certain strength, and then we were given allowances to be able to adjust the dose after monitoring. So working with the GP to be able to change the dose of the drug.
I see. Now, have there been any changes or temporary changes during this COVID period that has enabled you to assist people in the community or are there things that could be recommended immediately to assist the community?
So I guess for the continued dispensing has been absolutely fantastic for us. So we've been able to, instead of supplying only a 3-day supply of medication, we've been able to supply another month's supply of medication for all medications other than a few. So that means for anxiety and mental health, for cholesterol, for blood pressure, for diabetes, for, gout even, to prevent this happening. And then it's a one-off per 12 months. And then we try and arrange for them to then see their GP to have ongoing care. So it's not taking over, it's just a continued dispense of their regular medications.
So would you like to see that continue in a post-COVID environment for rural and regional areas?
Yes, so we have had it previously with our oral contraceptive and cholesterol-lowering medications, but with COVID, we have been able to use it for all medications. So this would be absolutely fantastic in all settings to allow another month's supply so that they have access to the GP in the next month.
Ms. Michaels, in the Society of Hospital Pharmacists of Australia submission, it says in 2017-2018, New South Wales patients were 48% more likely to experience an adverse effect from medicines than Victorian hospitals and 29% more likely than Queensland hospitals. What's the basis, or can you provide an insight into that data?
That's correct. Our submission does talk about that. We attribute that in part to the staffing ratios. So in New South Wales, as I stated earlier, there's around 1,300 hospital pharmacists. In Victoria, by comparison, there are 1,700. And of course, Victoria has a much smaller population than New South Wales. So the service ratios there simply aren't comparable. So you're not receiving the same rate of management of medication. So we don't see that as being sufficient for your population to be managed. So when you're seeing those kind of adverse events, that's not acceptable from our perspective. So those stats reflect the rate of care.
Okay, how does the scope of practice for a hospital pharmacist differ from the work that someone like Ms. Carter would do?
Hospital pharmacists, as a general rule, have a different level of training. So they operate potentially. So one way I would explain it, I guess, is that they operate in different specialty areas as a start. So hospital pharmacists operate on wards. They may have specialty training in areas such as oncology. They may be working with cancer patients. They may be working on a cardiac ward with people who are recovering from cardiac surgery, for example. They may be working on general surgery wards. So they're doing significantly working with complex patients and working with much more complex medicines.
Now, in earlier, we've had, I think this is our 9th hearing, and we've had evidence that there have been hospitals in New South Wales where there are no doctors on duty in the weekend. So what do smaller hospitals do involving, a small hospital? It would go to say that they would not have a pharmacist on duty. So what do those smaller hospitals do? Do they do it by
That's absolutely correct. They're simply not providing a service. They're simply not providing a service. Yep, that's correct. So what we would say is that it's a little.
Yeah. So what happens?
It's a little bit of lottery for a patient. So they may be discharged, as I was saying earlier, without receiving counselling from a pharmacist. So they might be handed their medication and simply not receive counselling around how to use that medication, what they should be doing when they get home. And as Ms. Carter was saying, they they might then end up in a community pharmacy. They may end up back at their GP. They may not take their medication correctly, and that's where we do see patients then bouncing back into hospital, and that continual circle of incorrect care or inappropriate care.
So you mentioned in your opening statement, and I actually wrote it down, where you said patients are released or discharged with, quote, a bag of medicine. So
correct.
That is going in a rural and regional areas with elderly patients. That is going to result in higher adverse situations. Is that correct?
Correct. So that's not what we see as high quality care. It's not what we aim, obviously, to provide for any of our patients. 7-day services are what we would like to see across all of our hospitals for all of our pharmacy patients.
So are there major hospitals in New South Wales that do not have pharmacists on duty 24 hours? I'm not talking about small MPSs, but I'm talking about major hospitals in New South Wales.
Yes, there are.
Can you give some examples of major hospitals that would not have pharmacists on duty?
A number of our major hospitals in New South Wales don't have 7-day services at this point in time. They're simply not resourced to do so.
But is that an acceptable standard in other states and territories around Australia?
There are also other states and territories that don't provide 7-day services at this point in time, but there are a number that do as well.
Right. Okay, but I want to take you back. So can you give me,
Greg, sorry,
if you can't,
can I just?
okay, well, okay, I just want to know if she could provide the names of those hospitals on notice. Thank you.
Can do.
Thank you. I
Thank
wasn't
you,
aware the time had got to that. The crossbench now. Kate, are you going to commence the question?
Yeah, I'm happy to. Yeah, thanks, Chair. I just wanted to continue some questioning with the Society of Hospital Pharmacists, so Ms. Michaels. Why is it that you outlined the Public Hospital Pharmaceutical Reform Agreement and the fact that New South Wales hasn't signed up to that, which I think we were talking about before, in terms of that means that patients are not really able to get the PBS drugs for 30 days. But why, when they leave hospital, what's the reason why New South Wales hasn't signed up to this?
Look, it's obviously been a decision that was made at a point in time. I'm not privy to why that decision was made. Governments make decisions at points in time. It's obviously historical, not for me to make that call. The reason that we think it's really important, obviously, or the reason we would like to see that decision reviewed is primarily around that access to medicines. So that 30 days of access provides, as we were just talking earlier, for that continuity of care when people do leave hospital with medicines in their hand. It gives them access of those days when they have left to be able to continue with that medicine, to receive that counselling when they leave the hospital, to know what they're doing with those medicines when they arrive home, to have that certainty when they are at home to utilise the medicines appropriately, to continue with that care, to have that time at home before they have to seek care back in the community.
Thank you. Going back to your submission again, which was a very good submission, so thanks for being a part of this inquiry. That it says that the medication-related adverse events compared to other states in New South Wales. What I think is most concerning about the chart that you've provided from 2011 to 2017-18 has Victoria and Queensland remaining very steady in those adverse related events, and in fact we have been increasing year upon year upon year. What does that look like for, like, clearly something has to happen in New South Wales about this, or by the look of that, those numbers are just going to get worse and medication-related adverse events are going to increase.
It does appear that way. I mean, I think what it looks like to us is that continued chipping away at the resourcing issues just, it appears from the data that if you continue to reduce that resourcing in hospitals, that it compounds basically. I mean, obviously that those resourcing issues and they're not simply about human resourcing, they're also infrastructure resourcing, et cetera, et cetera. So as that compounds over time, it obviously has an ongoing effect. So I think you're starting to see that. And when you look at that table, as you've pointed out, it is quite stark.
Thank you. I just wanted to quickly go to the Pharmaceutical Society now. Thanks for in your submission as well, which is also a good submission. You mention the importance of integrating pharmacists into Aboriginal community controlled health services. I was just wondering if one of you would care to expand upon that. Just like it sounds great. You said there's growing evidence, particularly that integrating pharmacists into Aboriginal community controlled health services can help increase life expectancy, etc.
Yep, I'm happy to field this one. Thank you very much for the question, Kate. So integrating a non-dispensing pharmacist in an Aboriginal health service, and what I mean by a non-dispensing pharmacist is one that is not directly involved in the community pharmacy process of dispensing a medicine. So this is where they're using more of their cognitive and clinical expertise with relation to medication management. So integrating these pharmacists in an Aboriginal health service does have the potential to improve medication adherence, to reduce chronic disease, and to reduce that medication misadventure, and largely to decrease preventable medication-related hospital admissions, which again is going to deliver significant savings to the health system. We know that this population is much more vulnerable when it comes to medication adherence, understanding the purpose of medicines and how they impact on health, and also in obtaining access to medicines, given that many of our Aboriginal and Indigenous neighbours are in quite remote settings. So by ensuring that there is pharmacists who are at that direct interface with these communities will ensure that not just education, but we're able to have transparency over how they're managing their medicines and ensuring that they have much higher rates of chronic disease like diabetes and cardiovascular disease. And we need to better manage this particular population.
Can I just...
Honourable Emma Hurst, Deputy Chair.
Sorry, can I just add that we were involved in an Immerse project, and I did spend some time doing reviews out at Brewarrina. So I was not involved in the community pharmacy. And this just showed to me the stark reality of the gap in rural health. We also did do this service in Gunnedah, and we have improved our relations with First Nations people. We've also improved compliance. Some people had had a heart attack and had stopped their medication, so we've got them now taking their medication again. So to Chelsea's point of having a non-dispensing pharmacist, but then it can also work in a community area if you've got good relations with the local services.
And to build just a last point on that, it's not just cognitive services that are being provided, but actual physical health-related services such as vaccinations. So there are numerous outreach programs that are conducted between a community pharmacy and these populations. And given the current climate, vaccination is so important. We know there are low rates in these remote areas, and pharmacists are imperatively involved in this service.
Emma, do you have some questions?
I do, yes, thank you. Ms. Michaels, you say in your submission that New South Wales public hospitals lack the investment and resources to meet acceptable standards for practice for hospital pharmacy services. Can you just expand on that a bit for us? What standards of practice are not currently being met in New South Wales?
Sure. So to give you some examples, so SHPA as the professional body, we set standards, for example, on the number of hospital pharmacists who should be working to a bed ratio, similar as you'd probably be familiar with, you know, a nurse to patient ratio. So, for example, for clinical pharmacy staff, we say there should be, you know, one hospital pharmacist for every 20 cancer patients, or one for every 15 haematology patients, for example. And it's not even vaguely close to that in New South Wales. It's miles and miles and miles away in where you are. As the example I was giving earlier, in terms of there being only 1,300 overall, it's not even within Cooee. So when you're talking about stats that are just so far away, you're not even coming within close to those kind of standards. So that's,
with that in mind, I mean, what's the most urgent things that need to be addressed? I know you've sort of covered it a little bit, but, you know, when you sort of say that, you know, we're so far away, you know, if we were going to prioritise what needs to happen, you know, what are those early stage actions that need to happen before we can, you know, get a little bit closer to where we need to be?
Look, I think on that basis, you'd have to say you just need to come to a very basic number. That's not even, those are kind of the more complex ones. So really, we say that, you know, you should have 1 to every 20 acute patient, and that I think is a very basic standard. That's where you should be in the very first instance, or 1 to every 30 stable patient on the wards. So I think that's you know, what I would set as a base level, and that's what New South Wales should be absolutely hitting in the first instance. And that's not in any way unreasonable. And that's what, you know, when the 1 to 5, you're very familiar with it, nurses, that's where we should be talking about for hospital pharmacists. And that's what New South Wales should be aiming for. When we were talking earlier about coming with the PBS, that's, you know, certainly one way for New South Wales to be looking at that. Signing up to the PBS reform agreement is one way to, you know, to start injecting some funds and coming back to looking at that, which would give, one, the benefit we were talking about earlier with the medicines for patients, which is obviously really effective, really useful, and two, another way to look at starting to potentially fund some of those workforce, which is desperately needed.
And if we still haven't, you know, considering we're so far away from where those standards need to be, I mean, what does that mean for patients on the ground? You talked a little bit about adverse medication events, but does that mean that, you know, we're seeing higher death rates in rural and regional areas because of medication confusions? And what else are we seeing, or what have you heard? What are the most horrific outcomes of the fact that we're so far from those standards?
You're certainly seeing a lack of service. That's absolutely what you're seeing. You're seeing, you know, more people coming back into hospital. We've talked about that. What we're seeing from our end, which is obviously our connection with our members on the ground, people are telling us that they're actually withholding services. So from the patient end, that experience is, you know, a lot of the time that they don't know the services they're not receiving. So, you know, that's a terribly unfortunate thing. So they can't say to you, you know, we don't know what we're not getting, but they're actually not receiving services, and that's a terrible thing. And we already know that in rural and remote areas that they're disadvantaged to start with. But effectively, we're hearing from our pharmacists that they are having to withhold services. They simply cannot provide what they should be providing. So, you know, in metropolitan Sydney, they're already not providing what they're potentially providing in metropolitan Melbourne, and that's not right. But then if you're coming further back out and you're in rural and regional New South Wales, they're not getting what they're getting in metropolitan Sydney. So it's just, you know, further back out in the circle of further and further disadvantage. So, you know, if you know, that circle back of less and less and less service. So I think that's what you've got to be looking at is, you know, less numbers of people on the ground, less numbers of services for patients. And you already know that all of that comes back to just a you know, medication misadventure effectively in the worst possible way.
Thank you.
Thank you. Thank you, Deputy Chair. Moving across to government members, who would like to
Chair,
ask the first question?
I'll take.
Honourable Trevor Carnes.
Oh no, West
Honourable West Bank. Honourable West Bank.
Thank you, Chair. I've got a little bit more hair here, a little less hair here. Thank you very much for your testimony today and your submissions. They're really great, and we've been able to draw down quite a lot of information from them. So thank you very much to each and every one of you for taking the time to not only write the submissions but appear today. Look, I just wanted to sort of drill down on some of the information that we've got in front of us, not only from your experience, but from other experiences we've had during this inquiry. We've looked at the virtual pharmacies model, and we know that we've got this grant that's available where we can actually have clinicians in small hospitals getting advice through the virtual pharmacy model, and actually being able to provide that information to their patients with the backup of the pharmacies on that virtual care model. How has your experience been with the use of that, and do you support a wider rollout of that? That's basically to all members of the panel.
It's Jerry Yik here. Thanks, Mr. Fang. Essentially, yes, I think we have to move to a situation where we have to support these type of individual models. And I would like to acknowledge my hospital pharmacy colleagues as leaders of innovation and research in this area. And I think these have been introduced because of the lack of workforce, hospital pharmacists, as pointed out by my chief executive, and as we all know and have heard. And it is really difficult to recruit pharmacists, and not just pharmacists, but also nurses and doctors, to rural and regional health services, whether that be a workforce issue, a funding issue. Even if you are successful in recruiting them, retaining them is also equally difficult as well. So as you mentioned, Mr. Fang, there is a grant at the moment that looks at virtual pharmacy services, and I'm aware of, I think Western New South Wales is one of the recipients of those grants. And we actually have spoken to some of our members who are involved with this. And certainly so far, the results that we've heard are really positive, and that's not surprising. This type of model has been used across Australia through pilot trials. Just I think last year, there was a Western Australian telehealth chemotherapy service which won an SHPA award. And certainly now, because of COVID-19 and the pandemic, where it's actually quite unsafe for certain patients to attend hospital because they're immunocompromised or they're elderly, it's unsafe for them to go to a hospital where there are other COVID-19 positive patients there. It is safer to provide them a virtual pharmacy service where you can do the regular service activities that they're missing out on, such as daily chart review, counselling, therapeutic drug monitoring, looking at your medication list, providing a medication management plan, discussing your care plan with nurses and doctors, and all those things that currently aren't being delivered for rural and regional New South Wales patients because there aren't sufficient workforce in those areas. So we absolutely do see virtual pharmacy services where perhaps if you can't attract a hospital pharmacist to move to a rural regional area, or it's only an MPS with a dozen beds, that the business case doesn't stack up, we understand that. And so now we live in the 21st century. We would all have NBN and the internet. You can actually use virtual pharmacy services, use telehealth models to deliver them services and collaborate with other practitioners to make sure that they do receive the full scope of pharmacy services so that they don't have an adverse event.
Thank you. And look, on that, I note a question from Ms. Fairman earlier about Indigenous care providers and the support that they get from pharmacy providers. We know that they're sort of they are a primary care, and primary care is predominantly, I guess, a Commonwealth issue. Ms. Felkite, you were talking about the support that is vital for those care providers to have. Do you think that the Commonwealth can do, what can the Commonwealth do to actually help support those providers, those primary providers, to Indigenous healthcare providers, and are things like the virtual pharmacy model of assistance?
I think that there is absolutely a place for using digital technology, and the telehealth situation that we've had during a pandemic perfectly demonstrates the utility of this service. I guess I want to echo what Jerry has said in terms of, in my opinion, I always believe that it is better to have someone on the ground. I think that there is going to always be more personability. There is going to be better uptake of recommendations when you have that personal link with people. However, recognizing the logistics, recognizing the particular geographic logistics with these particular populations, the most important thing is that they have access to the services in the first place. So I do see a role, for example, with telehealth, particularly when it comes to those cognitive services, and we are able to deliver home medicines reviews as an example, where we can review the medications of people with complex chronic conditions and ensure that the medicines are being reviewed, and that the doctor, again, it's a collaborative model with a prescriber around the most appropriate use of medicines. It could also include things like counselling as an example. So if a person needed to start on a medicine and they were a long way away from a community pharmacy, there are potential ways for the telehealth model to ensure that that supply of a medicine doesn't occur without appropriate counselling advice along with it. So yes, the short answer is absolutely there is a role for it. I think that we need to be considerate about how appropriately that role is used.
Thank you for that. I know in the area I live, I'm in Wagga, and so the health district here, the Murrumbidgee Local Health District, has been trying some innovative models around the way that we have those on-site pharmacies provided to the local health district, almost like an outreach program. So I was wondering, in the experience of the people that are providing us the testimony today, have you had the opportunity to have a look at how they operate? And do you think that there's scope that we could potentially widen that experience out to other areas?
I might start, but I think Karen will have the best experience when it comes to this particular model. The only thing I would really like to note is that your example of that outreach program is exactly the kind of boots on the ground that we really require in these areas, because while that digital enablement is good to an extent, as an example, it loses much of the other physical aspects, such as the direct monitoring of blood pressure, which a lot of community pharmacies and outreach programs are able to do by being there on the ground. And Karen, if you had any of those sort of examples in your experience with outreach programs.
I think it is important to have people on the ground. You have a better camaraderie and relationship with the patients, and you're there real time, so you can see any adverse effects of medications or any missed medications. We had someone recently who'd been to a specialist. Their son rang saying, I thought mum was getting a new medication for dementia. We hadn't received anything. We phoned the GP. There was a letter written, but the GP had thought the specialist had written a script. We then got the medication started that day. So I think there are different examples, but and you know, having more pharmacists in outreach areas is fantastic. But also you do have to have some people on the ground in those areas. So, you know, workforce issues are one of those things. You know, I love my lifestyle, and you know, I do travel to lots of different areas and love my rural pharmacy. But, you know, it is trying to attract those people to come and stay. And it's the same with GPs. You know, we're down to low numbers of GPs, and they're overworked and need a rest, and we need to get more people on the ground.
I just want to touch on the points.
Oh, I was going to say,
Just want to touch on the
David
points
Wyatt,
made
thank you so
by.
much for your testimony today. Thank you.
Sorry, listen, I'll provide Mr. Yick, you were going to jump in and say something, I believe.
Oh yeah, I just wanted to touch on the points raised by Chelsea and Karen on outreach programs to prevent admissions. That is really important. I'll make it a quick point. In other hospitals around Australia, there are provisions for outreach programs where a hospital pharmacist will go and visit you in your home if you're identified as a high-risk patient. So if you're a high-risk patient who's just had an organ transplant or had a stroke or had a heart attack, you're started on a whole raft of 5 to 10 new medicines when you leave hospital and go into your home. It's that post-discharge phase in the immediate first 7 days, immediate first 14 days, where you're at the highest risk of having an adverse event. You're at the highest risk of having a readmission. You're confused about your new medicines. So in other states, there are programs where you're identified and referred on to the outreach pharmacist in the hospital. That pharmacist will go and visit you in your own home within the first 7 or 14 days. Make sure that you're going well, make sure you're settling in, make sure there's no confusion with your new medicines, if you're experiencing any adverse effects, that can all be managed in the community with that pharmacist so that they don't end up back in hospital. Because of the workforce shortages in New South Wales and worse so in rural, regional, remote New South Wales, there are practically no outreach pharmacy services. And that's when you see people end up back in hospital over and over again.
Thank you. And on behalf of all committee members, can I thank our two witnesses from the Society of Hospital Pharmacists of Australia and our two witnesses from the Pharmaceutical Society of Australia. It's been very high quality evidence, I have to say. It's been a lot of detail provided to us for us to take away and read and understand, and fits nicely with what was very valuable submissions made by both organisations. So once again, on behalf of committee members, can I thank you very much for making yourself available today. That now brings us to the conclusion of the sessions this morning. We are going to take a break now, and we will be resuming at 12:50 p.m. Can I invite committee members to please mute and turn off your videos for the break before us, and I'll see you back at 12:50 p.m. Thank you very much.
Good afternoon all. Can you hear me? It's Andrew here from the Secretariat.
Hello, yes.
Hi,
So you
Thank
can
you,
hear?
Dr. Lord.
Paul Wrigley here. Thanks, Andrew. Can hear
Hi,
you guys,
Paul.
Ellie. Yep.
Great, I can hear you too. And Dr. Wenham?
Hi, Andrew. Good afternoon, everyone.
Excellent.
Hi, everyone.
I can hear you. We're just waiting for members to rejoin, and we'll be proceeding and going live in a moment. So please have your oath or affirmation ready, and you can now mute your microphone until prompted.
Thank you.
Thanks. Chair, it's Andrew here. We've admitted the witnesses and tested their sound.
Good afternoon. How are you?
Well, thanks.
Right. Secretariat there?
Yes,
Yes,
Chair,
Chair.
we're
It's Andrew
live.
here.
Hi, how are you?
Well, thank you. We've admitted the witnesses and checked their sound.
Wonderful. Okay.
We're live and ready to commence whenever you're ready.
Okay. Okay. Well, we'll get this afternoon's session underway for what is our public hearing today for Portfolio Committee number 2, inquiry into health services and health outcomes for regional and rural remote New South Wales. We had a very productive morning with some excellent witnesses providing some most valuable evidence, and all the committee members are looking forward to hearing from a number of further expert witnesses this afternoon. We have witnesses in the next session, which will take us through to approximately 1:35. Those witnesses in the first instance from what is the Specialist Palliative Care Physicians and Clinical Director, Far Western Local Health District, appearing on behalf of the Australian and New Zealand Society of Palliative Medicine, Dr. Sarah Wenham. We also have joining us Dr. Susie Lord, who's a board member of the Faculty of Pain, the Australian and New Zealand College of Anaesthetists And we have finally Associate Professor Paul Wrigley, who's a member, Learning and Development Committee in the NSW Regional Committee for the Faculty of Pain Medicine, the Australian and New Zealand College of Anaesthetists. So thank you all very much for making yourself available. We'll need to go through a formality, first of all, to have you formally sworn or affirmed to give your evidence this afternoon. So in order, I'll actually ask each one of you, if I could please, to state your name, your position title, and swear either an oath or an affirmation, whichever you prefer, the words of which should be provided to you. Once that's done, there'll be an invitation to make opening statements, and then when that's complete, we'll move towards the questioning of you by committee members. So that's the format we'll follow. So could I first of all ask Dr. Wenham, could you please formalise your appearance today?
Yes, good afternoon. I'm Dr. Sarah Wenham. I'm the Specialist Palliative Care Physician for the Far West Local Health District, and I'm representing AmSPAM here this afternoon.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Dr. Wenham. Could I now please move to Dr. Lord?
Hello, yes, I'm Dr. Susie Lord. I'm a specialist pain medicine physician, staff specialist with the Children's Complex Pain Service based at John Hunter Children's Hospital and serving the Northern Child Health Network. And I'm also a board member of the Faculty of Pain Medicine.
Thank you, Doctor.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Dr. Lord. And Associate Professor Wrigley.
Yes, hi, I'm Professor Paul Wrigley. I'm a specialist pain medicine physician, and in terms of who I represent here today, I am the medical co-chair for the Agency for Clinical Innovation Pain Management Network, and I also have a number of positions within the Faculty of Pain Medicine.
Thank you very much. I'll get you please to either swear or affirm your evidence, sir.
Thank you. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. And thank you to all. I know that you're very busy, in fact, extremely busy medical professionals. And I know you've taken time out of your busy day to be available. So we thank you very much. Can I acknowledge, before we start with your evidence, the fact that both the organisations have provided submissions with respect to the Australian and New Zealand Society of Palliative Medicine. Your submission stands as submission 458 to this inquiry. It's been received, processed, and stands as such, and it's available on the inquiry's webpage. And with respect to the Australian and New Zealand College of Anaesthetists Faculty of Pain Medicine, your submission stands as submission 475 to this inquiry. Equally, it's been received, processed, and also stands as a submission. And in both of those submissions, they are very good and provide some very useful information for this inquiry. I'll ask each organisation through one of their witnesses to make an opening statement. Given that committee members had actually received and read the submissions, you don't need to go into submissions in detail in your opening statement, but perhaps set up your broad position on matters, and that will then facilitate the questioning. So perhaps if we start with the Australian and New Zealand Society of Palliative Medicine, Dr. Wenham, would you like to make a opening statement?
Yes, please. Thank you. Mr. Chair and committee members, the Australian and New Zealand Society of Palliative Medicine, AmSPAM, would like to thank you for this inquiry and the opportunity to appear before you today. As I've said, I am Dr. Sarah Wenham. I live in Broken Hill and work across the Far West New South Wales. I'm employed full-time as the Specialist Palliative Care Physician for the Far West LHD, and I am the elected co-chair of the Agency for Clinical Innovations End of Life and Palliative Care Network Executive. However, I would like to emphasise that I am appearing today as the representative for AmSPAM. I am not appearing on behalf of the Far West LHD, New South Wales Health, or the ACI.
Thank you for that, clarifying that. Yep.
Thank you. AMSPAM is the specialist society for medical practitioners who provide palliative care for people with a life-limiting illness across Australia and New Zealand. We promote the discipline of palliative medicine in order to improve the quality of palliative care for patients and support their families. Our members are all doctors with an interest in palliative medicine and include specialists, doctors who are specialists in other disciplines, and general practitioners. We have 561 members, including 121 based in New South Wales. Palliative care is an approach that improves the quality of life for patients and their families facing the problems associated with life-limiting illness. Palliative care is not just for those in the last weeks or days of life, but occurs from diagnosis right through to death and supports families in bereavement. People who are dying and their families require care and support 24 hours a day, 7 days a week. There are a number of challenges in providing palliative care to those living in regional, rural and remote New South Wales. These challenges lead to highly variable access to and quality of palliative care. For example, some patients benefit from dedicated specialist services. Others rely on care provided by GPs, community nurses and residential aged care staff. Some patients can be admitted to a specialist hospice. Others only have the choice of dying in their local acute hospital if home is not an option. And some patients can access 24/7 palliative care support. Others could only contact their clinicians during working hours. Consistent data is not available to determine what the need is, what medical practitioners are delivering care, with what training, to what quality, or what the patient experience is. Despite the challenges, there are many positive features of providing palliative care in regional, rural and remote settings. Local services offer a sense of familiarity, community and continuity, while clinicians often go above and beyond for their patients and their families. AMSPAM wishes to see equitable, consistent and high quality provision of palliative care across the whole population. We believe this inquiry represents an important opportunity to understand the exact need of patients, families and communities in regional, rural and remote New South Wales, understand the true state of palliative care in these areas, including provision by the state, federal and privately funded services and clinicians, and address the need for increased resources to facilitate greater consistency and quality in the delivery of palliative care services, particularly ensuring that trained and credentialed medical practitioners are integral members of the multidisciplinary palliative care team. Thank you.
Thank you, Dr. Wenham, for a very clear and precise opening statement, which will set up the questions very nicely. So thank you for that. Moving now then to the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists. Would it be you, Dr. Lord, making the statement, or would it be Professor Wrigley? I wasn't quite sure.
I'll be making the statement today.
Thank you very much. Please proceed.
So I'm Susie Lord on Awabakal land in Newcastle, representing the Faculty of Pain Medicine. The New South Wales faculty works closely with the Agency for Clinical Innovation Pain Management Network, which Professor Paul Wrigley is representing today. We are jointly committed to the National Strategic Action Plan for Pain Management endorsed by Minister Hunt in 2020, which calls for a clear focus on people in rural areas, recognising their high burden of acute, cancer-related and chronic non-cancer pain. I will focus on chronic pain due to burden, cost and inequity, but can respond to questions on pain more broadly. The New South Wales Pain Management Plan 2012 to 16 established 5 part-time chronic pain services in regional New South Wales. These regional services were designed for low volume, low complexity care, but they've since been shown to have high complexity caseloads due to high prevalence of pain, chronic conditions, cultural and other trauma, and socioeconomic disadvantage. Timely care cannot be provided with part-time funding. Moreover, recruiting and retaining staff is difficult. The tenuous sustainability of the part-time services is a threat to access and outcomes for people in rural New South Wales and a reputational risk for the ministry. Growing telehealth tentacles from Greater Sydney is not the best solution, but the Ministry no longer has an accessible contact with whom to address this problem. We ask the committee to recommend that the Ministry reinstate a contact person or department to re-engage with the pain management network and, as a priority, establish full-time staffing capacity for those pain centres currently serving rural communities. Regional hubs, leveraging local connections and the hard-earned trust of their communities, are best placed to deliver flexible combinations of face-to-face, outreach and virtual care for rural people with pain. Thank you.
Thank you very much, Dr. Lord. So we'll move now to the questioning. Just to explain to the witnesses, there's the groups represented on the committee in terms of political representation. We have government members, we have opposition members, and we have crossbench members. And what we will do is that we will move between each of those three groups and provide them with equal time to ask you questions. And will take us through to approximately 1:35. So are people agreeable with that format? Does that suit you all?
Yes.
Okay. Well, I'll commence as an opposition member, and I'd like to first of all direct my questioning to Dr. Wenham, and with my questions also to the Faculty of Pain Medicine. In both instances, I'll be drawing on your submissions, which I found to be both very, very helpful. But first of all, Dr. Wenham, with your submission, and I'll specifically refer to some paragraphs in your submission, and my questions will arise from that. On the first page at 2.3, Dr. Wenham, the issue about the question of the availability of the palliative care specialists in regional, rural and remote New South Wales, and the positioning of such specialists in those locations and the challenges around which you see. Could you please elucidate on that?
Certainly. So New South Wales Health have committed to providing funding for every LHD to have a specialist palliative care physician. I think that the challenge with some of that is recruitment to those positions. Each LHD has a physician. Like for myself, I can speak to that out here in Broken Hill. I'm based in Broken Hill and I cover the whole Far West Local Health District. But obviously there's only one of me, and we cover a very large geographical area of up to 300 square kilometres. That outreach needs to cover the other areas in our district. I know for certain other areas, they've either not been able to recruit to those positions funded by the ministry, or they've got positions that are funded within a particular geographical area, but within the LHD, but not within other LHDs. I think the other challenge within that is it's not just about specialist physicians, but it's also about other appropriately trained medical staff. So a number of LHDs or areas will have GPs that have, say, done some advanced skills training in palliative medicine. Some may or may not have achieved their clinical diploma through the Royal College of Physicians. And then there are other areas that rely on other medical staff, so GPs with a special interest who may or may not have done specialist qualifications. I think part of the challenge is that we actually don't know what areas are actually receiving have access to either specialists or GPs with specialist training.
Dr. Wenham, could I ask you, in regards to an undergraduate who enters into and completes their basic medical degree, just looking at that degree, how much training do they receive? This is to the best of your knowledge. If you need to take it on notice, feel free to do so. But what training do they receive in their medical degree, their base medical degree on palliative care?
So all universities, I believe, do some basic training, but I think it really depends in terms of which university you go to and what clinical placements that you do as to how much training that you get. So I think some people will get some and other people won't. I mean, if you'd like me to take it on notice, I can certainly approach the universities to find what's included in their curriculum. and actually get that exact information for you.
No,
Certainly, AMSPAM would advocate for all undergraduates receiving palliative care and palliative medicine training.
No, thank you. I have heard examples provided to me in general conversation with people that there are instances where they believe that there's a minimal amount of training in palliative care as part of their undergraduate degree. And it did sort of surprise me. They were actually talking in terms of only hours of training inside a 6-year degree. And I would have naturally thought that it probably would have been a unit or so. But anyway, if you could take notice, that'd be great. But that leads me on to my next question about the burden that falls to GPs in regional, rural and remote New South Wales, dealing with the palliation of people, not just at the end of life. I mean, as you describe, palliative care or supportive and palliative care can take over a period of time, but those particularly treating people at the very end of their life, these general practitioners, if they've not received or sought to do some specialty training in the area of palliative care, but they are still able to palliate, are they not, a person at the end of life through providing some basic pain management? Is that the case?
Absolutely. So any medical practitioner, and we would certainly advocate for that, and that's why our membership is not just specialists, it's specialists with interest and general practitioners are able to provide end-of-life care for their patients. And we would certainly advocate that. I think even as a specialist, we would advocate for general practitioners to be actively involved in their patient's care journey because they've known them and they've often got that long relationship, not only with the patient, but with the family themselves. And they're going to be following the family through into bereavement as well. But I have to say that some general practitioners have an interest and do their own education and training, do their own credentialing through the clinical diploma. However, there are other general practitioners that it's not really something that they have an interest in. I would say also from a general practice perspective, whilst absolutely all clinicians are able to prescribe pain medications and other medications used within palliative care, I have to admit there is a reluctance, and I think that's recently happened with some of the things that have happened with around PBS opioid prescribing, and AMSPAM does have a statement on that, which we would be able to provide you out of notice as well, if that would be
notice,
useful.
Doctor, that would be beautiful. Can I just refer back to a point you made in your opening statement, which I thought was quite salient, where you were talking about palliation and palliative care, not just in the context of the individual patient being treated, but obviously that patient dying in the context of a person with family members. They might be their immediate family, but extended family as well. And also the local community. And we know that communities can be very tight, and particularly those outside the big cities. People tend to know each other and often involved in socialising and playing sports and what have you. Could you just give us a bit of insight into this issue that the palliation and palliative care is more than just dealing with the patient per se at that very end of life?
Absolutely. So the definition of palliative care includes holistic care of the physical, social, spiritual, emotional, cultural needs of the patient and their family. And so that's certainly something that, as a specialist within palliative care, we work as a broad multidisciplinary team, and that includes nursing, allied health counsellors, our pharmacists, and we often have volunteers who are members of our actual clinical teams as well. But we really do acknowledge that the broader community is a huge part of providing palliative care for patients, and particularly, as you say, in small rural communities. And it's around supporting families and people doing the shopping and people dropping off meals and looking after the kids and looking after the grandkids. And I don't think you can ever quantify those types of things that are there, but I think it does just show that providing palliative care in small communities is much more than just the clinical care, and there's really a need to provide that social, emotional and cultural care too. And I think that then moves on to, particularly within our Aboriginal communities, the importance of being able to care for people in their own community and allowing them to be able to be cared for and to die on country if that's their wish, and making sure that we have the services that can actually support that from a clinical perspective too.
Thank you very much. Now, just I've been informed that my time has expired. I did have some questions for Dr. Lord, Professor Wrigley, but I'll seek to try and circle back after the others have asked their questions. So thank you very much. Can we now move to the crossbench members? And would the Deputy Chair, are you commencing with your questioning?
Yes, wonderful. Thank you so much, Chair.
Thank you.
Dr. Wenham, and just going back to a comment as well that you made in your answer as well to the Chair's question, and I think you also mentioned in your submission that it's not clear who is providing palliative medicine in rural New South Wales and what qualifications they possess. Can you explain what you mean by that? Is it that it's not being tracked or monitored by the government?
I think it's quite challenging, and that's because there are multiple different providers providing palliative care. So it can be provided by specialists like myself. It can be provided by a geriatrician who's caring for somebody who's dying, or a nephrologist who's caring for somebody with end-stage kidney disease, or a cardiologist. It can also be provided by general practitioners, providing that care in the community. And I think it's because that care is being provided by specialists within the state system and general practitioners within the federal system, that there is no single way of tracking that information. And similarly, we know within a specialist context who has their fellowships with the Australian College of Physicians, but actually there's no way of tracking whether a general practitioner has done advanced skills or training or has a clinical diploma. So that's really what we're saying is that it can be provided by many different people, and should be provided by many different people because of, as I mentioned before, the importance of that care being provided by the right person at the right time in the right place, i.e. in their local community, if that's what people want. But I suppose it's just, how do we make sure that everybody is getting high quality care without actually knowing, because palliative care is being provided across the state and federal systems.
So we could essentially have a situation where there are patients in rural and remote areas where there's nobody with any kind of specialist skills in this space.
Absolutely. So they could be being cared for by a different specialist or by a general practitioner who, as I mentioned when I answered the Chair's question, yes, will have their general training within general practice, but we don't know whether they've actually done any specific palliative care training or not.
You've also mentioned in your submission that GPs aren't provided with any kind of reimbursement for travel for home visits. And obviously that's going to make it harder for people in rural areas to access this service. Do you think that introducing a travel reimbursement scheme would actually encourage more GPs to offer in-home services in rural areas?
I think certainly palliative care is something that, as people get more unwell throughout their disease trajectory, it's not as easy for them to be able to travel into a clinic. And so therefore, I think there are two things. It's about making sure that the care can be provided in the most appropriate place. And if that is the patient's home, that the clinician providing that is not only reimbursed for their time, but also their travel time. And I think that's the other thing. The other real challenge is how we can provide appropriate medical support for people who are living a long way away from the clinicians as well. So certainly I think we need to be much broader, and our AMSPAN would certainly advocate for medical practitioners to be reimbursed not only the face-to-face clinician time, but everything that is actually included in providing the most appropriate care to the person in the most appropriate place. And if that's their home, yes, absolutely, we need to be thinking about travel time being included in that.
And do you think that reimbursement or the lack of reimbursement is the biggest barrier, or are there other big barriers as well to ensuring that kind of care in the home?
I think there are probably many different barriers. I think some of the other support services in providing care in the home and just sort of knowledge, skills and confidence. But I think one of the other things is actually what can be provided in the home. It's, as I said before, palliative care is very holistic. It's not just about the clinical care, but it's about the social care. So making sure that particularly people in remote areas have access to appropriate home care services, that people are appropriately trained as well, that can support families and other carers in that home environment as well, because I think one of the other things that we see is when people don't have that home care support, and they're trying to care for people 24 hours a day, 7 days a week. Sometimes the only option they feel is for them to be admitted to hospital if there isn't appropriate home care support. And I think the more rural you get, often the more challenging that can be as well.
Yeah, absolutely. Thank you. I think my time's expired. Thank you.
Thank you, Deputy Chair. Kate Fleming.
Thank you, Chair. I've just got a couple of questions with it's either Dr. Lord or Associate Professor Wrigley in relation to your submission. Sorry, I'm flicking between screens and not doing a very good job of it. Where you talk about Aboriginal community controlled health organisations, when you say that it's evident that there is a keenness to partner on staff professional development in the fields of acute cancer related and chronic pain management to enhance Aboriginal community controlled health organisation pain management, and then you recommend that there be kind of more funding for these initiatives. Would either of you care to expand on that and also tell the committee why that's so important, and perhaps by highlighting the gaps that are there now as well?
Sure, I'll start, and Paul may wish to add. I am also the chair of the Reconciliation Action Plan Committee for the faculty, and have a personal interest because 20% of the kids I treat are Aboriginal. So we certainly work with Aboriginal medical services and have seen children in those services when that suits the child and family, and work in with the services which provide that care. And it's very clear from discussions with them that controlling, having secure protected funding to those services to allow them to choose what educational resources and professional development they would like is really important to those services. So that's about education and professional upskilling of people on Aboriginal medical services. There's a huge there's a disparity in the experience of chronic pain, so that we understand that 1 in 3 Aboriginal people experience chronic pain, and in a small paediatric pain service to have 1 in 5 come into a tertiary pain service, as inaccessible as tertiary pain services might seem, suggests that there is a really unmet community need for chronic pain services to children and adults, and 50% of Aboriginal communities are people under the age of 24 in most places outside the urban centres. So it's a really huge need, and there's a gap, and we need to really look at cultural safety. That Agency for Clinical Innovation has done a lot of work in developing a broad understanding of culturally safe communication strategies within the pain sector, and they've developed a website called Our Mob, which helps provide community resources for people with chronic pain, adults with chronic pain primarily. And there are some programs, community programs, that have been developed or adapted from others and then used within communities. So those things are really helpful.
Sorry, that was a great response. Can I ask then, I assume one of the consequences of, you said 30% of Aboriginal people, I think, have experienced chronic pain. So one of the consequences of that, I assume, is using alcohol and other drugs, like in ways that aren't great to, if they can't access quality pain management. That would be, is that something that you see quite often too, Dr. Lord?
We don't have data on that. There are some data that suggests that there are more people in Aboriginal communities who abstain from alcohol, and that some of our preconceptions about that may be misunderstood. But I think broadly across those communities and also others, where there is an absence of best practice pain, access to best practice multidisciplinary pain management, people end up being prescribed opioids primarily and other drugs, and having a really biomedical focus. Our faculty's framework is a socio-psycho-biomedical framework. So we think that the social determinants of health are incredibly important for pain and pain management. And so we do think that the gap in pain services does result in community harm, and some of that is through drug and alcohol use. It's not specific to Aboriginal communities, but when it occurs in those communities, it adds to the disadvantage in them. So I'll leave space for Paul to also speak.
No, I just
Yes.
so Professor Paul Wrigley here. I would just concur with what Susie's quite eloquently said, and it's not a feature just of Aboriginal health, it's across all cultures really. I think having a interdisciplinary, in other words, not just medical, but clinical psychology, physiotherapy and other allied health services is really crucial to look at the whole person and provide useful strategies that are beyond just the medications and interventions that can be provided.
Thank you very much, Professor. We now move our questions to government members. So would that be the Honourable Trevor Khan or Honourable Wes Fang? Do we have a government member who'd like to jump in?
Oh, sorry, Chair, I had the mute button hit. It's Wes Fang.
Honourable Wes Fang, please proceed.
Thank you, Chair. And thank you very much to all our participants today for giving your time and appearing. We've heard already today during this inquiry about the importance of networking. We know that where we've got some difficulties in providing a full suite of care to health areas across the state, we can access networking services. Can you provide some insight as to how those networking services work with regard to palliative care? And how do you think that we might be able to provide some better services through that networking experience for those people that are receiving that palliative care?
Absolutely, thank you. So yeah, networking is so important, and I think it really is the only way that we can actually provide palliative care to rural and remote areas. So speaking from my personal experience out here in the Far West, we work very closely with, as I've already mentioned, general practitioners, but also our local residential aged care facilities, the Royal Flying Doctor Service, who service all of our remote facilities and areas, as well as Marimar, which is our local Aboriginal medical service. And I believe all of the other LHDs will have those connected relationships and networking where we. So a lot of it happens informally on the ground, where clinicians work very closely together for an individual patient. But I think organisations like AMSPAM and the other professional relationships also allow us to network together and to work and to provide that sort of general education and training. So from palliative care specialists, for example, to other specialists in other disciplines and general practitioners. I know for our district, we will support education and training for our RACF members, staff, and other community-based services. I think part of the big challenge, however, is the different funding of those different models. We're all working together, but Healthworks under state, RFGS is Commonwealth funded, as is aged care, as is general practice. So I think that's part of the challenge is how do we, when we're all working under, I suppose, slightly different funding models, then actually all pull together. And how can that be more streamlined? And then you throw in home care services and those types of things as well, which are also essential to palliative care services. And then I suppose the provision of medications. That's another thing, which some are available through PBS funding, others aren't available on the PBS, and so need to be provided either privately or through hospital pharmacy services. So again, just not forgetting hospital pharmacists and community pharmacists in there as well. I don't know whether I've got the answer to it. All I know is that for us, building relationships on the ground is something that's really important. But if there is some way that I suppose can be supported, for example, we have multidisciplinary team meetings where we get everybody together, and I think within health, that's funded through one way, but if there can be some way that you can bring private practitioners into that, so general practitioners and pharmacists into that, so there can be that funding for them to be able to be part of those broader networking, both on an individual patient basis, but also from an education and training perspective. That helps then local clinicians work together, both as teams, but for individual patients too.
Do any of the other participants have any views that they might? I can see Dr. Lord is, she looks like she's in anticipation to answer, so I'd be very keen to hear your opinions as well.
Look, I think for pain medicine, it's also essential. We go across acute and chronic and cancer-related pain, and we work with we are in essence a multidisciplinary faculty, so people train from general practice, physicians, anaesthetists, psychiatrists, surgeons, all train as pain specialists, and a growing number of GPs. And in New South Wales, the main network is the Agency for Clinical Innovation Pain Management Network, and it includes consumers and allied health staff as well, and has been a very effective instrument over time, but its sharpness has been lost by not having a connection with the Ministry for Health. And I'll hand over to Paul because he's the current chair of that network.
Yeah, I think so. Paul Ridley here. Thanks for your question. I think one of the key things we wanted to communicate to the committee was that in the information you received initially, you weren't given the broader network that is available. And we had just 3 recommendations that to get you to consider actioning if that was possible. One was to, as Susie mentioned, to reinstate a contact person within the Department of Health that could help us to address maintenance of what's there, but in fact be able to enhance what we can recognise is impacting on the provision of care, particularly for rural region and remote New South Wales. So a voice would be great, but also to establish better full-time capacity in those part-time regional services who aren't able to attract people because it's very difficult to go out to a region and be employed part-time. And with that, one of the things we've noticed is that the Ministry for Health has dropped all of their service level agreements, and we would recommend that the ministry look at reintroducing a service agreement, and it can be a very general one. Possibly all LHDs maintain a full-time multidisciplinary pain management service resource to provide primary care, or to resource into LHD collaboration to achieve this. So I think if there is an agreement to provide a pain service, it then puts the onus on the LHDs to actually resource what they've already got, but also to look at providing something for those that don't have it. We have 8 services available, but at least 5 of them are part-time. I'll stop there.
No, thank you for that. No, I was just getting the notifications that are coming through. I've got about 2 minutes left. I just wanted to touch very briefly. Dr. Wenham, you were talking about the different funding models, and we know obviously that there are components that will fall under the primary health network, which is the feds, and then there's obviously the LHDs, which is the state. Do you have some views as to how we could better integrate the services to enable the provision to be more streamlined? And I think that was the word that you were using before, was the streamlining the process. Obviously, that you can see that there's those coordination issues, but I'd be keen to know whether you've got some views on how we might actually progress that forward.
I mean, I think it's. I think really what we need to be doing is getting everybody together. I mean, I really only can speak from my understanding of specialist funding. I mean, I think we certainly do need to be having funding of Aboriginal health, the RFDS and also local GPs together. I think it's about making sure that we're funding everything that needs to be funded, but not double funding as well. And I think it certainly does need to be across the board. In terms of just going back to your previous question about networking, whilst I'm not here representing the ACI, as with the pain network, the ACI does have the end of life and palliative care network across that's already set up across the state that does have representatives from all of the state general practitioners, RACF, and I think sort of using some of those networks that are already there to tap into to actually define what needs to be done, how it needs to be funded, and then look at some sort of combined funding models, or looking at ways of what are our needs and how can we fund those out of the different pots. But I think ultimately a lot happens through the goodness of people's hearts, both in general practice and in health services. And I think if you actually quantified what happens, probably there's a lot of stuff that happens that doesn't actually get funded, and that's rural communities for you. So yeah, I think there's work to do to define it.
My time will have expired, but I just wanted to say thank you again for the great work that you're all doing and in the space, and I really commend you for coming in and appearing today. Thank you.
Thanks, Wes, and thanks, Dr. Wenham. Just in the remaining few minutes, just on behalf of the committee itself, I just must ask just a couple of questions to take us through to the end of this panel. And can I just specifically draw my questions and direct them to Dr. Lord and Professor Wrigley, specifically in regard to your submission. And if you've got your submission, close by or you can access it, I'm looking at the bottom of the first page going on to the top of the second page. And on the bottom of the first page, it says, chronic pain is a major and growing public health problem throughout Australia. And there's a citation there, and it says, population data and extensive experience suggests that people living in rural and remote Australia, and then it says, and New South Wales in particular, experience a higher burden of chronic pain and face more barriers to accessing best practice and pain management compared with those residents in urban areas. I'm just wondering, can you comment on that specific reference where it says, and New South Wales in particular, what's that based on? Research or evidence or what?
I believe that's in relation to population density. So the rate, by virtue of the number of people living in New South Wales, essentially.
Right.
Not in relation to a differential rate of burden. We don't have that data. We hope that after 2022 National Health Survey that we'll be able to report by jurisdictions the actual incidence of chronic pain in Australia and across New South Wales and different states and have comparative data. But at this stage, we don't have that. The issue is that there are people living in rural areas have a higher burden of socioeconomic disadvantage, and that is highly correlated with the experience of chronic pain.
No, thank you. And just finally, just on page number 4, sorry, 1, 2, 3, 4, page number 5 of your submission, under the heading planning systems used by NSW Health in relation to pain service provision, which are terms of reference E. And you have, Dr. Lord referred to this earlier, the NSW Pain Management Plan 2012-2016. Has that plan been replaced by a plan to follow that, or are we in a limbo period at the moment? What's the situation?
From a New South Wales perspective, we are in limbo. We have a National Strategic Action Plan, which was endorsed by Minister Hunt at a federal level last year, at the end of last year, and the states have been asked to consider how they can action that plan at a state level and deliver actions that will meaningfully reach the goals that have been agreed are very valuable and important to curb this public health problem of chronic pain. So I think what the state would benefit from doing is working with the ACI Pain Management Network and the Faculty of Pain Medicine on how to action the pain management plan within New South Wales most effectively for people with pain.
So, sorry, just to conclude, does that mean that it would be your submission that there ought to be a new plan put in place, or that the plan that expired in 2016 just needs to be implemented on a continuous basis?
I'll let you answer, Paul.
No, look, it needs to be revised. You can't set a plan in 2012 and expect it to last forever. And
I wouldn't have thought so, no.
We've learned so much, but we need
Yeah.
to then come back to the table and say what we've learned and
Yep.
what needs to happen. We need to have that voice back within the Ministry of Health. And we have a platform for that with the most recent National Strategic Action Plan that's been endorsed at a Commonwealth level.
But it would be helpful, would it not, to have New South Wales as a state itself augmenting that to have its own pain management plan?
That's right.
Absolutely.
So a task force was developed before the New South Wales plan was made. Recommendations were made to the minister, and then the minister responded with that plan. So that process probably needs to be redone, or at least the Commonwealth plan be adapted.
Adapted,
yes. New South Wales.
Well, that brings this panel to a conclusion. I speak for, I think, the whole community.
I think the Honourable Donnelly is gone, but we thank you very much for the Honourable Committee members for listening to us and inviting us today.
Thank you.
Thank you very much.
Thank you very much.
Emma, I think it's over to you.
Yeah, can I suggest, Emma, that unless, Greg comes back, you're it.
Yep. It looks like we might be getting him back. I think the little orange thing's gone. Oh, no, it's back.
Through you, Deputy Chair, the witnesses for...
Come in and let's break to allow the other people to come in, and then we can come
Yep.
back. Yeah.
Thanks, Trev. Yep.
Through you, Deputy Chair, the witnesses are ready to be admitted at your instruction.
Yeah, sorry, what was that you said, Trevor, that you wanted to...
The witnesses should be invited to come in so they can get up to speed, and then if Greg's not back by 1:40, you can kick us off again.
Yeah, great.
Hello. Can I test? Emma, can you put your thumb up if you can hear me?
I can hear you. I can hear you.
Thank you, Emma. Okay, because I lost connection. Greg and I are both at State Parliament, and I think we both have had an internet cut.
Right.
Yeah.
Good afternoon, Professor Smith. Excuse me, through you, Chair, Deputy Chair. Professor Smith, Professor Forster, Professor May. We'll just do a quick sound check before proceeding. I'll do that one by one. Professor May, can you hear me?
I can hear you, Andrew. Can you hear me?
Yes, I can. Thank you. Professor Smith, can you hear me?
Yes, I can hear you clearly. Can you hear me?
Yes, thank you. And Professor Forster, can you hear me?
I can, Andrew. Thank you.
Thank you. We'll be proceeding in a moment. We've just got a few connection issues with our chair in particular, but we're live and we'll be proceeding in a moment. Please have your oath or affirmation ready. Thank you. You can now mute your microphone until prompted.
Shall we start, just in case the chair takes a while, shall we start with actually just swearing in each one of those witnesses? If I could start with Professor May, if you could just let us know your title and either swear an affirmation or an oath.
Thanks, Emma. So I'm Professor Jenny May, and I'm here in my capacity of the Director of the University of Newcastle Department of Rural Health, and I'm also a practicing GP. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you, Professor May. Could I move to Professor Smith, if you could let us know your title and also swear in either an oath or an affirmation?
Yes, so I'm the Executive Dean of the Faculty of Science and Health at Charles Sturt University, and I'll swear an affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Professor Smith. And Professor Foster. I think you're on mute, sorry. If you could just let us know your name and title and swear. That's okay. If you could just let us know your name and
start.
It's always like that with the technology. Just let us know your name and title and swear either an oath or an affirmation.
Sorry about that. I'm Leslie Forster and I'm the Dean of School of Rural Medicine at Charles Sturt University. And I'll swear an oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Wonderful. Thank you all so much. I'd like to now open to the opportunity for people to read out an opening statement. Professor May, did you have a short opening statement you wish to give? Please proceed.
I do, Emma. So thank you. So thank you, committee. I speak to you as an academic with an interest in workforce, a practicing GP who incidentally practices palliative care in reference to the last hearing, and a Tamworth resident with a personal and professional investment in high quality rural services. The last few months and the advent of COVID is in a reality in rural communities has created an escalating challenge to try and maintain rural health services with an increasing focus not only on acute services, but also challenges to scale up immunisation, testing and pathology. While these challenges are new and pervasive, it is important that we use this opportunity to consider whether the gaps that we are seeing are those of a pandemic, or whether there are underlying and structural concerns that need to be articulated and addressed. In the next 2 minutes, I make 2 points. Rural health services need a local, well-trained and highly valued workforce, and the systems of funding and support to rural health are incredibly interdependent and interlinked. So a movement of a lever in one sphere can have unintended consequences, especially when it comes to income autonomy with a net loss of rural workforce and a long time to replace. I've observed the gradual loss and ongoing loss of localised capacity with increasing reliance on locums, on fly-in, fly-out services and the need for rescue and retrieval. And it is the result of multiple small, unconnected decisions over 20 plus years. Rural health services straddle multiple service models and funding streams, including general practice, aged care, acute services, and are delivering at a time when there is a pervasive focus on generalism, on specialism above generalism, and you just heard that in the last hearing. Whilst my submission is mainly about the role of undergraduate rural health student training, that's simply the beginning. Best evidence demonstrates rural origin and positive rural exposure are both critical in attracting and encouraging medical students to careers in rural areas. Evidence nationally and in my own patch here in Tamworth with the Joint Medical Program demonstrates high levels of intent of graduating medical students as rural preferential interns in our hospital system. However, whilst I've witnessed success from both these predictors, it is not sufficient, and even if it was doubled or trebled, it would not provide us with the workforce we need. It is clearly not the only strategy, as it is not currently translating into a sufficient workforce quantum. There is pressing need to reorientate our pre-vocational and specialist training. Dr. Jones, during your hearing in Gunnedah, said despite her best efforts, JMOs who choose to base themselves in rural areas are provided with no assistance if they want to rotate to metro areas. Yet JMOs who come out of our urban base are paid up a grade and provided with accommodation. Historically, this practice, while well-meaning, is a value message. Metro rotating doctors are worth more than those committed to rural areas, and they need to be compensated for coming to the bush. Such a small thing, such a poor message, and seemingly no avenue, including raising in Parliament, to get it changed. Australian trained medical graduates are consistently choosing better paid and supported training that is urban based. Specialty training, while primarily in rural areas, is the exception, not the rule, and you've heard that so many times through this inquiry. And with metro-based networks geared to rural rotations as opposed to rurally based training. The solution, however, is not as simple as insisting, and I'm not suggesting it, that we rurally base all specialist rotations. Any training that is perceived by our colleagues as second-rate training and occurs where resourcing is clearly constrained and where workload for our junior trainees is far greater than their metropolitan trainees will fail. Dr. Scott clearly pointed this out in his submission in Gunnedah. So unfortunately, when we're reorientating our training systems simply to promote rural training, it won't be enough unless we make it a suite of supports and manage the trends that have been well evident over the last 20 years. The challenge is instead related to the inherent valuing and messaging of generalist training and changing that balance in our overall workforce between generalism and specialism. Whilst 20 years ago a wide scope of practice was embraced and supported, there are now significant barriers and perceptions of barriers in providing wide scope locally based care. There's no doubt that this is more than a rural problem, but our rural areas are the canary in the coal mine. And clearly this requires collaborative work, which is occurring in small part as part of the National Medical Workforce Strategy. The strategy aims to improve collaboration between federal and state, to rebalance supply and distribution, to reform some of those training pathways and to build generalist capacity. And whilst understanding that growing Aboriginal and Torres Strait Islander workforce, looking after doctors and others' mental health and wellbeing and adapting our models of care are obviously primary. So we've got to make sure that the key consideration of this strategy is the geographic maldistribution that we are so aware of. And at a jurisdictional level, we have a responsibility to share data, collaborate, and really try and align these high-level levers. So training a new workforce, which may take years, will not be successful if we don't clearly articulate where and how our health professionals should be working. Time and again at this inquiry, you've heard about service reduction and disappearance. I call it systematic disinvestment, again happening incrementally over years. When services are reduced and the funding buckets change, there are no accessible general practice services, and where there are no accessible general practice areas, avoidable hospitalisations increase. There seems little flexibility or appetite to manage these high-level issues. Importantly, let's look for transparency. Even within the system, our many speakers have described the challenge of getting information on what the community implications are for funding and planning. The lack of support to general practice and primary care and the importance of integration, which we feel so keenly in rural areas, must be addressed. Virtual care has its place, but in my view does not compensate for in-person, wide-scope rural generalist nursing and medical skills. So despite all of our and many of our well-meaning attempts to provide quality rural health services, we find ourselves in a situation where we are seeing reducing critical mass. So if our intent and our reality is a downgrade in those services, please can we majorly ramp up retrieval services and just-in-time care and be honest and accountable about this trade-off to our communities. Rural health has passionate, committed players and a significant direct and indirect interdependence with mainstream health services. We will achieve comparable health outcomes and high quality care if we clearly commit at both levels of government and as communities to invest in an honest and accountable rural workforce and infrastructure. Thank you.
Thank you, professors. And it's the chair back. And can I just thank the deputy chair for holding the fort whilst I was offline there for reasons that I still don't fully understand. So let's return now to the part of the hearing where we defer to members to ask questions.
Sorry, Chair. We've only heard the opening statement from Professor May. We haven't actually heard from either Professor Smith.
I apologise. I do apologise. We'll move then to the second opening statement.
Thank you, Chair. And I'm Professor Smith, and I'm providing a statement on behalf of both Professor Foster and myself from Charles Sturt University.
Thanks, Professor. Apologies.
Oh, no, you're fine. We have prepared a statement, and I really would like to table that firstly. And I'm not planning to read through that, but we have forwarded that through to the Secretariat to become part of the minutes of the meeting. I will, however, I think that Professor May has really outlined, and I would understand the pair of us being together in the this session indicates that we have a lot of commonality between the key points that we wish to raise and represent. Certainly, our main thrust of our tabling of our opening statement and also our submission has been the role that education plays in the future health workforce and the contribution that educating beginning practitioners in their entry to the workforce can make. And so, look, we'd certainly like to reiterate, rather than reiterate the issues and things that Professor May has already raised, start engage in a conversation about some of the solutions and the contribution that education can make. So I'll hand back to you and take that as a tabled statement.
Thank you very much. And we look forward to receiving that statement for us to be able to read. So that's great. Thank you for that. That provides us now with that opportunity to ask questions. And to the witnesses, we have represented on the committee from the opposition, crossbench and government. So if you're agreeable, we'll rotate that across the three groups, starting with the opposition. The Honourable Walt Secord. If you're there. Are you there, Walt?
Thank you, Chair Donnelly. Now, I just want to alert my colleagues that Greg and I are on the same internet service at Parliament here, and I'm getting the little symbol. So if I disappear, be ready to resume.
Thank you.
Professor Smith, you actually in your statement you talked about practical solutions to work education. Can you actually spell out what you're suggesting? Because we as a committee make recommendations to the government at the end, and that's where the expert advice and what you would like to see us recommend.
Yes, certainly. The main recommendations, and this obviously comes from the lens that we have as education providers. In Professor May's statement, she highlighted that really the evidence base that supports that if you look at the pipeline of a future health workforce, that pipeline is strengthened if you bring people into it from rural environments, you educate them and allow them to have experiences in rural areas as part of their training. And then you provide them with job opportunities in rural communities at the end of that, and job opportunities that are respectful of their scope of practice, that provide them with professional development opportunities and are secure employment with training associated with it. So I think we know that that's the pipeline that is effective in building an effective and strong rural health workforce. I think the recommendations we have are what can we do along that pipeline to strengthen that along the way. One of those for us is actually looking at that educational experience where students have the opportunity to learn in a rural environment and to gain experience. The challenges of the workforce are such at the moment that for our rural practitioners to engage in education is difficult for them. They are stretched across service provision, but we know if they can engage in education, then we can build the next layer of workforce and strengthen that in the future. So some of our recommendations are actually looking at the funding and resourcing and surrounding network that surrounds clinical placements for students. Both for the student to take part in that, but more particularly for the educators who are in the sector to be able to support those students. We do have a predominance of placements for students across the board at the moment that are in our public healthcare system. There is less participation in the education from the private sector and the NGO sector. That's not necessarily a willingness, it's just the capacity of their service, the way they deliver services to accommodate students. And I think that if we're looking at the solutions, looking at how we can strengthen that education is one of the things we should be looking at. Look, I'll just pause there, as I'm sure that others wouldn't. Yeah, or I'll take a further question if you like.
Well, can you sort of give a bit of context? So, is it in fact getting rural people to remain in rural areas, or is it to in fact get city people who come to rural areas to experience and then remain? What's the better approach to increasing workforce in rural and regional areas? Is it keeping rural people there, or is it enticing city people to rural areas?
If you wanted the most impactful of those, the evidence would suggest that taking someone who's grown up in a rural area and educating them and providing them with strong education gives you the strongest return. But that's not the sole solution. There are many people who've grown up in metropolitan environments who have undertaken education in rural locations who've become strong advocates of rural practice. So I think, to answer your question, there's neither one of those that's the perfect solution. What is important is acknowledging that a strong and meaningful and engaging experience in a rural environment can encourage people to want to work in that environment and stay there.
Professor May, would you like to add something to that? I saw you nodding.
I'd love to, and just to amplify what Megan says. So rural origin by itself, we take currently 30% of medical students in New South Wales are of rural origin who attend medical programs. Now, of those, 30% of them currently go rural. So you can see our net return is 10%. Now, what we need is a workforce of at least 30% or 40% probably to get population and geographic equity. So we must work not only with rural origin who have our most positive predictors of return, but also with what I call conversions. So positive rural exposure, providing opportunities for metropolitan students to be exposed to rural practice and to take it on. But really the key word that both Megan and Leslie and I are working on is positive. The difficulty is if we expose medical students to demoralised, really stretched, overworked rural clinicians, then obviously that's not going to necessarily translate to positive rural exposure. So it's really building, as Megan said, the environment which is conducive not only to good clinical practice, but to teaching and learning as well.
Professor Leslie Forster, is there anything that you'd like to add or observe in relation to the...
Sorry, did you finish? You seemed to disappear.
Oh, I'm sorry. I'm sorry. Is there anything that you'd like to add to what they've just said? Sorry, there's a dip.
Yeah, obviously, I mean, we've all worked together for a long time, and I support both Jenny and Megan, obviously. But something that I assume you understand we take for granted, when Jenny's talking about the 30% of students who come from the country, but only 30% of them stay and set up practice. One of the big problems, of course, that exists is that, as she said earlier, they need to go away to do their training, often in Sydney. And when they go, they're at that age where they've just graduated, they fall in love, they buy a house, the person that they decide to marry says, I'm not going to the country, and so they don't come back. Whereas I think if we can have a situation where students from the country do their training in the country and do their postgraduate training in the country, they are the ones who probably more than anyone else are going to stay. In our program that we're setting up, we had 824 applicants for our very small number of positions, which to me indicates, the first year of a program, which always people would be a little bit anxious about, to me demonstrates a huge unmet need in rural people who want to study medicine and are prepared to work in medicine. All of our students are rural origin, and they're all at this stage wanting to stay in the country when they've graduated. We're very much encouraging them as part of our program to look at rural generalism, and we're developing a pipeline where they do their clinical placements where they come from, or in some cases as far away as possible from where they come from, depending on their inclinations. But we are doing that with the whole aim of maintaining those relationships and roots that they have in the country, so that they will in fact want to stay there and help this crisis.
But are you finding that if students do come, that they're going to the major regional centers, so that it will be quite easy to get someone to go to Tamworth, Orange, Wagga Wagga?
Yep.
But going to, I don't know what the actual phrase would be, but smaller centers that would have major hospitals. So is that the real challenge?
I think that's what's been happening. I think that they have the regional centres, as you say, are quite popular and have become quite desirable. And that's why, again, we've turned it around so that our students are starting in general practices in small towns, and they will continue from there to work in the later years. They will go to the regional hospital, but they will have built up those community links. And we've done that deliberately to try to say to them, general practice is really interesting, and a community is really interesting if you build that up, and this is where you want to come back to, and to us that's the way that we've decided is the interesting thing has been that we've approached a lot of general practitioners who are stretched and are working hard, and said, this is what we want to do. And they've said, I really think that's a great idea. That's going to work. Let me in. I'll teach students. So we've had a lot of remote general practitioners who have agreed to become part of our program and teach the students in the hope that they'll follow on and work in their practices or near them.
Professor Smith, I saw you raise your hand. Do you want to add something to that? I actually saw you raise your hand.
That's right, and so did Jenny as well, so she wanted to add to it. I think one of the,
Okay.
I think take one of your questions is that about the difference in the size of the regional centres, and I would say there's a couple of comments to make about that. One of them is about where placements can occur and students gain the experience, and the second one is about where actually a job opportunity will exist for somebody once they've completed that training. From a placement point of view, and I'll probably take my answer in the context of the wider health workforce. Clearly, medical practitioners is a really integral part of our health workforce going forward, but it also applies to our nursing workforce and our allied health workforce as well. It is easier for us to get placements for our students in the larger regional centres. So that's Wagga, Tamworth, Orange. That's a reality. There are more health practitioners and the system is better integrated to provide a comprehensive experience for students. It becomes harder the smaller the community, most often because the health practitioners in those regions are in part-time positions or maybe across multiple areas and sectors. And so trying to bring that collaboration together to get a comprehensive experience for student is more difficult, the smaller the facility. I mentioned before that the predominance of placement and education is taking place in the public sector, so that's the hospital-based sector, and in smaller communities you tend not to have as big a facility, and so it's harder. To the piece about the job, so one end is once you've got somebody having experience, we'll educate a student who will go, fantastic, I want to work in a rural environment, and then they'll try and step into a job, but the job doesn't exist in a position that is well designed for someone who is new to practice. That's because someone might have funding and they would really prefer an experienced person, or it might be a fractional position, or it might be a contract position, and the skill base that someone has on graduation is not well designed for them to step into a new graduate position. And I'm particularly talking about allied health and nursing as opposed to medical, which of course has an internship-based system. But there's some important parts, I think, when you get out of the bigger centres and you start looking at some of the issues around smaller centres and the capacity to provide health services in those in the future.
Mr. Chair, with the indulgence of Trevor Kahn, could we have Professor May extend on the answer, please?
That would be great, and then we'll move to the crossbench. Thank you, and thank you, Honourable Trevor Kahn.
Thank you, Trevor.
I value that opportunity. Thank you. And it was just simply to extend it and say you have highlighted a really important problem, which is, for instance, when medical graduates finish their medical degree, they can only do rural preferential or internship, the PGY 1 and 2 years, in a metropolitan area or in our selected regional centres. So you're exactly right. Even if you have someone who is rurally intending, the most rural they can go for internship is one of those regional centres, and they do provide a little bit of a magnet, if you like, to our trainees. Now, as you've heard from the specialist point of view, many of our rural trainees are choosing specialism over generalism, and 60+% of our medical graduates specialise and less than 30% are now going into general practice. And that's what I was alluding to, is as we lose generalism and that focus of generalism in our workforce, then these problems will become more and more acute.
Thank you very much, Professor. Thank you. The crossbench, is it Kate? Are you kicking off, or Emma?
Yeah, thanks, Chair. I'm happy to. Thank you for appearing and also for your submissions, which are which are incredibly detailed and really helpful for the inquiry. I just wanted to go. Which one have I got open? Charles Sturt. I just wanted to ask about particularly the cost of clinical placements and the cost on the students of clinical placements as well. Down, like in this paragraph, you've said that really in relation to nurses training, that the cost of part of it is increasing at a faster rate than funding for the course. So who's sorry, I have lost. So Charles Sturt is.
That's it's probably me. I think I'd be the most appropriate person to
it's sometimes difficult to flick between all the screens and have the agenda on as well. Sorry about that.
And we've got three professors too.
Exactly.
Well, we can just go Megan.
If the professor could answer, yeah.
And I'm happy with Megan, trust me.
Thanks, Megan.
Look, it's a really important question about, because I think the cost of placements in this particular case is the cost to the student of that experience. And I think we have a particular lens on that. Often we've more recently looked at the idea of students will do a clinical placement in a regional area from a metropolitan location. There's that idea that they get sent out to the country. I think one of the particular things we notice is that our students will move and do placements across a number of regional areas. And what that brings with it is a cost that relates to, I think costs are multifactorial. One of the costs is the cost of just accommodation. Where are you going to live and how are you going to live there, and where's that availability of it? And we've had increasing ability support, particularly through the Commonwealth funded RHMT program, which has allowed us to start to put accommodation in locations. But that was a major issue for us. We've had students living in caravan parks, hotels, and various other environments which are not great and are expensive for them. So that's one of the costs. The costs of travel are greater. We can have a student go from the mid-north coast to the Murray River in terms of seeking placements, and that's a long distance between them. If they are undertaking paid work, they will need to forego that paid work for the period of time that they are on clinical placement. And by the time they get to their final years, they are long blocks of placements depending on it. And so we've had students as well who will drive home at the weekend to go back home to do their weekend work so they can actually earn an income to then go back to placement the next week. So that nature of what is the cost to the student is quite considerable, on top of then all of their living expenses and everything they have in between. And I think that is exacerbated for a rural student compared to a metropolitan student who may be able to stay in their home base accommodation where work's down the road and travel out to a placement and come back at the end of each day. So I think it is a particularly unique scenario that is worse for our students, for us in that environment. I hope that answers your question.
Yeah, that was really good. Thank you. Particularly, I suppose, for nurses, for example, who aren't kind of in terms of like, income generation throughout their career. That's a big sacrifice in some ways to make. It's all about sacrifices really for our nurses at the moment.
And I think I'd probably add to that, I think what we do, and this starts to extend the cost into what do they return, they make a significant contribution into the healthcare system. Absolutely, they get their education, and everyone respects that they're not fully qualified practitioners and they need support, yet they make a difference every day to the quality of healthcare in our communities. I've seen hospitals that are dependent on the throughput of students through to maintain the level of care that they're providing because they are part of that workforce. So you've got the cost to them, the cost of their education, and yet they're making a contribution, and that's a fair sacrifice I have right up front.
Thank you. I do have just one more question before my time is out, which I don't think has been covered, but it's in the Charles Sturt submission in relation to the HETI, that health services have lobbied HETI to upgrade the system. I don't think you've talked about that, but in this submission it says that to date the efforts have been unsuccessful to update the HETI system. Kind of potentially interested in why, and just to explore some of the reasons behind that. I think that's important too.
Look, I can probably only speak to our experience of working with HETI over the years, and I will say that HETI actually does work. It does work really constructively with us, but they are facilitating placements and facilitating it across the board. The number of placements that HETI will try to administer and provide oversight with their ClinConnect system is enormous, and we've seen that rapidly increase. They do have a system which is a computer-based system, but rural is small within that. So for them to have the resources to be able to upgrade a system to particularly meet the needs of a rural practice, I think is just not within the sort of scope of all of the work they're doing. So I think that's why rural's small, and when you have the scale of some of the size of the metropolitan placements in there, it's just where it would sit for them. But I would encourage that. That's certainly our experience on our side, but I would think that they would have a response to that as well.
Thanks, Kate. Thank you, Professor. The Deputy Chair, Emma Hurst.
Wonderful, thank you, Chair. Just following on from the last question around systems, I was just wondering about the ClinConnect system as well, Professor Smith and Professor Foster. In your submission, you said that it doesn't actually allow health students to indicate the preference for taking their placement in regional or rural areas, which seems like such a really obvious thing that should be able to be fixed. Why hasn't that actually changed in the system?
I think there's probably something to understand about the ClinConnect system in that it's kind of like a hotel booking system to some extent, but it often relies on the relationships that sit at the back end of that. So what you will do is have a relationship with a healthcare provider, and then the ClinConnect system allows us to administer that. But what it has, if you can think about a very busy health system that is loading placements in there, and you have a very busy education system which is trying to match the students with a placement, that the rural voice can get lost in that system well and truly. And when we're looking at just trying to ensure actually the numbers of students we have get through, it can be hard to represent the quality of a clinical placement in a rural environment as a strength within that system. And then out of the choice, if a provider wants to provide a placement in a rural location, then it just may not look as attractive to providers as some of the other areas, particularly from a numbers point of view.
Thank you. Professor May, you talked about this positive rural exposure for when students are actually taking placements in rural areas. And we've heard about the cost and the big sacrifice financially. But I was wondering if you could sort of further unpack this idea of a positive rural exposure and what we need to be ensuring is in place to make sure that it is a positive experience.
So my comment relates to the thinking that any placement is a good placement, and that I guess it goes also to one rural area is just like another rural area. So the difficulty is in finessing and assisting students who have exposure to what are the real benefits of working in a rural community. So that is the continuity, the integration, the community exposure and experience of dealing with people and families, which is absolutely, why I'm still practicing in a rural area after 30 years. It's extremely attractive, and we need to ensure that students get that experience. And Megan's discussion about ClinConnect is one of those little glitches that often gets in the way of us making sure that those placements are preferenced and that we can deliver those attractive placements. Now, I have to say really positively that as a result of the funding through our HMT program, which employs me and has allowed us to build some very good pieces of accommodation and infrastructure in regional and rural communities, that we have, I think, gone a long way to both validating and offering that positive rural exposure. Now, the question is, what are the metrics? And your question is such a good one. What are the metrics of knowing that we are succeeding? And as I mentioned in my opening statement, one of the dramas is that if every rural student chooses a rural preferential recruitment in a regional area, is that success when we know that we're then going to lose a large number to specialist practice? So it's such a good point, and I spend a lot of time trying to decide what's positive, but I think what I'm trying to say is that it's a connected experience where we have engaged supervision and where we can provide a student with the support to actually take that on in an experimental way. One thing I would say is that I think it's time-based. So a 2-week taster in a rural community is just that. Sometimes we call it medical tourism. But 6 or 12-month location in a place like Tamworth, Gunnedah, Moree or Inverell, which are in my patch, I think they're the ones that will predict long-term rural return if they're positive.
Thank you for that. And in regards to sort of, if we're able to get students into these rural areas, and we talked a little bit about the data of 30% and then 10% of students, do we have any sort of information about long-term retention once they're sort of located in those areas? Do they tend to stay, for a long period of time?
So yes, Emma, although I think one of the things the committee needs to think about is retention needs to be recast. All right, the retention that I grew up with, which was one family doctor in one rural community for 25 years, I think that's yesterday's model. I don't think that our students of today are really looking at spending their whole lives in one spot, providing the sort of service that many of our clinicians in the past have spent. I think we've got to recast that and rethink that. And what I want to do is to train medical students to be rural doctors, but they can also be urban doctors, and they can also go on Medicine Sans Frontières, and they can do a lot of other things, because what I see is a great deal more mobility in our health professional student workforce. And what I think is that it is equipping students with skills and trainees with skills that work well in rural. And if they're good in rural, they're going to be good anywhere. Because as your previous speakers talked about in the palliative care section, they not only need the competence to practice, but in rural areas, they need the confidence. And that's what I call clinical courage. So if we teach them clinical courage, I think they're going to be good practitioners no matter where they go. And we need to accept that a 5-year retention period is probably not too bad.
Thank you. Thanks so much for that.
Thank you, Deputy Chair, and thank you, Professor. Moving now to government members. The Honourable Trevor Khan or the Honourable Wes Fang?
I think I'll start with Professor May, seeing we're probably communicating from relatively close by to each other. So what I'm drawing upon is the evidence that was given at Gunnedah, which plainly you've accessed. This is not only for you, Professor May, it's for the others as well, but I'll direct it at you. But also the evidence given at Lismore. And what particularly interests me is this. When we talk about attracting somebody to work in as a general practitioner in Tamworth, it seems to me we're talking about a different issue than in some of what I'll describe as the satellite towns around the major regional centres. Obviously, Gunnedah is one, but you could look at a number of others, Grindai, etc., are in this area. And in those satellite towns, it seems to me that what we've seen has been a shedding of general practitioners, for instance, and other health workforces, so that now we are in, it seems to me, almost a critical phase in a number of those towns. So getting a general practitioner to come to work with you in Tamworth, I'd suggest is a bit of a snack, like they've got a support structure around them. Throwing them into some of these other towns where the professional environment has been shed or the professional support has been shed is another quantum level of difficulty. So what I'd ask you to address, Professor May and the others, is how you deal with those centres, the satellite centres, which really seem on the evidence, and frankly, I know, to be in a really problematic stage in terms of the provision of services.
Well, first of all, can I heartily agree with your diagnosis? Because I think there is a big difference. There's two things I would say. One is we are actually better off in terms of provision to those regional centres than we were probably 5 to 10 years ago. And you will understand and know that there was a time when you couldn't get a general practitioner in Tamworth.
Yeah.
So I think that's where the RHMT program and emphasis on rural origin and the sort of programs have succeeded. So I think we need to talk that as success rather than anything else. But what you point to is absolutely right. And in the appendix on my submission, you will notice a table where I tried to look at modified Monash different areas. And what you're alluding to is that the workforce issues in MM3, which is our regional centres, very, very different from MM4 to 5, which are our regional procedural hubs. And they have been most affected by both the loss of services and the concomitant loss of practitioners. So if you're asking me about solutions, first of all, I'd say, yes, that's where the problem is. And RDAA did mention this loss of sentinel maternity services as really the beginning of the end for many of these procedural centres. And we are now in a situation of providing locums and very difficult workforce gap filling because we lack that critical mass. So that's where the Rural Generalist Training Program has to come in, but it has to come in overcoming the many barriers that say, if we are going to support you to do obstetrics and to do anaesthetics and to provide an emergency service of a high quality, there must be numerous practitioners. So we need a critical mass. It's no good importing 1 or 2 doctors. They will burn out quicker than they arrive. And that has been what we have seen. We need to support them. How do we need to support them? Well, we need the critical infrastructure and an investment in the critical infrastructure that makes that high quality practice. And we need to invest in the accreditation support that encourages them to have the clinical courage and to be valued to do what they do. And currently in our medical system, rural generalists and those working in those MM4 and 5 areas are not valued anything like they need to be valued for the scope of practice that they provide and the amount of care that they give.
Professor, do you want to make any additional contribution?
Look, I think Jenny's captured it really well. I think the only other contribution I'd say is that a doctor needs a multi-professional healthcare team wrapped around them. There's no point having a doctor in the town if there's no pharmacist. You know, someone's then got to drive to the regional centre to collect their medication, or you know, or that there's not the nursing services and support people. So I think the other thing is to think of a community as a whole and a health service as a whole, not individual practitioners, because that's the system that they need and the levels of care that are within that are appropriate for the healthcare for the community. You know, I don't think anyone's saying that we're needing tertiary level services in these communities. What we're saying is a good primary healthcare structure that allows people to receive the services that are appropriate for the size of the community that they're in, and that is a multi-professional way of thinking.
Well, that brings me to what I think is my final question, because I know Natasha has one, and that's this. We seem to have received a good deal of evidence which is either hinted at or been straight out a suggestion that we should increase, in a sense, the professional scope of some of the related health professions that in a way would, in a sense, patch over some of the problems that we're facing in some communities, but actually erode the base of general practice. And I see the benefits of it. I also potentially see the disadvantage that it may actually reinforce the evacuation of general practitioners from the towns. So that's my opinion. Would any of you like to express a view in regards to that, Professor May?
Jenny and I probably have different views. Yeah, go.
I certainly would, Trevor. And I think what makes us so sure that we're going to attract this other workforce that won't have exactly the same issues in terms of recruitment and retention. Yep. And our conversations with nurse practitioners over the time have been there are very, very few nurse practitioners who elect to have a wide scope of practice in a rural or remote area, and they are fantastic where they are. But is that the intention of many? No, it's not. So the workforce challenges that we talk about are actually multidisciplinary. And the approach has to be, as Megan said, multidisciplinary, but it needs to respect that we actually need whole clinicians in our rural communities, not part clinicians, as you've alluded to. And the undermining that has inadvertently occurred about both the income base, but also the scope of practice in a negative way rather than in a complementary and cooperative way. For instance, GP obstetrics could have been maintained if there had been arrangements and agreements between special obstetricians and GP obstetricians in a networked sense. So there are lots of areas where we could have retained skills in a different way by cooperating and collaborating better. But you're right, there is a risk if you undermine scope, if that's what we're trading on, and that's really what our model is predicated on.
Professor Smith, do you want to?
Yeah, the comment I was going to make, and I think it articulates well with Jenny's, is that many of our practitioners, so our GPs often, they do have a general skill base and they're called upon to do that. But there are often other practitioners within the community, like if there is an allied health practitioner who has skills that are perhaps not being used at the top of their scope of practice. So they don't need to go outside their scope. They just need to be able to work fully within the scope that they have and to be able to draw on those resources and practices. So, for example, physiotherapists do really good work in triaging and managing back pain within the primary healthcare sector. But if a person with back pain has only one option, and that's to go to the emergency department and see an emergency doctor for the treatment of their back pain, we're not using the physiotherapist at their full scope of practice to provide the appropriate healthcare in that community. So I think before we get to the question about starting to bleed outside of people's scope or ask people to work outside their scope, we have to ask, have we created a system that uses people to the best of the scope that they actually have for the people who are there?
Thank you very much. Listen, that's brought us to 25 past. Natasha McLaren-Jones, did you have a quick one, or would you like to put that on notice?
I did. It was just in regards to nurse practitioners, and we've heard at previous hearings, obviously the desire for more nurse practitioners, but some of the challenges have been the number of placements that are being available. Others have been the challenges of actually balancing their current work with undertaking the study. I'm interested to know about not specifically the number of placements available, but whether or not the number that are available, has it been reached full capacity, and what are the challenges for people uptaking those placements?
Megan, do you want to take that? It's a little outside my scope. I could have a go, but I'd be only giving you a local observation of my my visibility of placements in Hunter, New England, which is probably not answering your question.
Yeah, look, and it's probably a little bit outside mine. Charles Sturt had a nurse practitioner program that we were offering a number of years ago, and we removed that program because we didn't have the demand for the course wasn't there. Now, if you think about it, you think, well, Charles Sturt's university in a regional community, if there was a pathway, people could see a pathway through that course into practice, that they would have taken it. So it was a little bit before my time as the dean, but I can only say that I think we probably haven't got it right for people, for nurses to want to pursue that pathway, to see job opportunities and to have the time in their current work to make the decision to undertake that study. So I think that's probably what I can offer at this point, but clearly it's not working if we weren't able to see students wanting to come through that pathway. And whether it's a placement issue or whatever structure we've got right, I don't think we're quite there, and I'm certainly that nurse practitioners themselves would have more to offer on that.
Thank you.
Thank you very much. Well, listen, on behalf of the committee, can I thank you all very much. 3 professors. I think it's the first time I've ever had a panel with 3 professors. The combined experience, expertise and knowledge has been very, very impressive. You've obviously given a great deal of thought to this, not just from the academic point of view, because of your respective roles in your tertiary institutions, but very practical thinking about how it can be transferred into delivery of improving and enhancing health and medical services in regional, rural and remote New South Wales. So we thank you very much for making your time available this afternoon. If there are any questions on notice or supplementary questions that may arise following the reading of transcript, the Secretary will liaise with you all. So once again, thank you very much for your submissions and your contribution this afternoon.
Pleasure, happy to.
Thank you.
Much appreciated. Thank you. So this will now move us towards our final panel for this afternoon. It'll take a few minutes to change over, so don't leave us, and we'll be back very shortly with our final panel.
Chair, all witnesses are in the lobby, so we'll now admit them and check their connection.
Thank you, Andrew.
Good afternoon to you all. It's Andrew Road here from the Secretariat. I'll just check your sound one by one. Professor Hayward, can you hear me? Sorry, Professor Hayward, I believe you might be on mute.
You would think I would know. Good afternoon. I hope you can hear me. Thank you.
Yes, I can hear you. Thank you. Ms. Nisbet, can you hear me?
Yes, Andrew, thank you.
Thank you, I can hear you. Dr. Giddings, can you hear me?
Yes, loud and clear. Thanks, Andrew.
Thank you, Dr. Giddings. We're live and we'll be proceeding in a moment. Please have your oath or affirmation ready. Thank you. You can now mute your microphone until prompted. Over to you, Chair.
Thank you, Andrew. This now brings us to our final panel session for today. We have three very experienced witnesses in terms of their background and knowledge about matters health in regional, rural and remote New South Wales and beyond. We have Professor Bridget Haywood, I should say, Ms. Leanne Nisbet and Dr. Paul Giddings. In that order, I'll ask each of you, please, for dealing with the formalities to state your name, your position title, and then swear either an oath or an affirmation, whichever you prefer. You ought to have the words in front of you. And then once that's been done, we'll move to opening statements. And then following that, we'll move to the opening up of questioning from committee members. So that's the planned format. It'll take us through till about 3:15 or thereabouts this afternoon. So once again, thank you all very much for making your time available. We know that you're very busy. So perhaps starting with Professor Bridget Haywood, could you deal with the formality of becoming a witness?
Good afternoon, Chair, and thank you to the committee. May I offer the affirmation that I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the whole truth. Shall be the truth, the whole truth, and nothing but the truth. And for the record, my name is Professor Bridget Haywood, and I am the Vice Chancellor and Chief Executive Officer for the University of New England, Australia.
Thank you, Professor Haywood. It's great to have you this afternoon. Ms. Leanne Nisbet. Could you please deal with the formality? You may be on mute.
Thank you. Sorry.
No, that's okay.
Yes. Thank you.
Thank you.
So I'm Leanne Nisbet. I'm the project manager for the New England Virtual Health Network, which we call NEVN. I'm also a PhD student in the Faculty of Health and Medicine at University of New England. I'll offer an affirmation. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thank you.
Thank you very much, Ms. Nisbet. And Dr. Giddings.
Thank you, Chair. I'll offer my oath, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God. And for the record, my name is Dr. Patrick Giddings. I noticed you mentioned Paul Giddings, but for the record, it's Patrick or Pat Giddings.
I apologise.
Not at all. And I'm the Chief Executive Officer of Remote Vocational Training Scheme Limited, which is a not-for-profit company that administers the Commonwealth-funded Remote Vocational Training Scheme.
Right. Thank you very much. Thank you very much, Dr. Giddings. Now, can I, before proceeding, just acknowledge and thank you all for your submissions to this inquiry. From the University of New England, your submission has been received, processed, and stands as submission number 466 to this inquiry, and it's available on the inquiry's web page. and with respect to the remote vocational training scheme, Dr. Giddings, your submission is submission 465 to this inquiry, and equally has been received, processed, and stands as a submission and thus evidence to the inquiry. Committee members had the opportunity to access and study your submissions. So in your opening statements, there's no need to go into detail specifically of content of your submissions, but perhaps through your opening statement, open up a overall position of the issues which you think are important, and that will lead to our questioning shortly. So starting with the University of New England, would it be you, Professor, who will make the opening statement?
It will, Chair. Thank you.
Thank you, Professor.
As I said, good afternoon, and I'm very appreciative of the opportunity to present in front of you. As indicated, the university has made a written submission about the development of an education and training programme to service the needs of remote and rural communities. In the University of New England, our remote and rural communities stretch from Tamworth through Armidale and through to the small villages, towns and settlements of the New England Northwest area. And increasingly the issue, which I think can be summarised in one clear piece of data, is the ability of the community to access health in place rather than to receive healthcare and support by travelling great distances. I'm sure you as a committee will have received many reports and other forms of evidence which will identify the healthcare deficit, and as a result of that, the deficits in the quality of life years that result for those living in remote and rural communities. Last year in New England alone, 36, as I understand it, 36 positions of general practitioner were advertised. Only 3 could be recruited. This year, it is our lived and practical experience as a university, as part of that community, that we are supporting and delivering, for example, vaccination programmes into small, remote and rural communities, because there is no other provision to enable the vaccination of our communities. So we live in an environment of a modern, successful nation that has not yet resolved how to ensure equity of healthcare to all. And for us, in resolving that equation, we are proposing a new model of health education and training, which is about taking the training and the healthcare provision to the community as part of a connected, networked model, the NEVIN, the New England Virtual Hospital. We are in the process of piloting this initiative with collaboration from Inverell and many other partners. And we believe that this is a model that should be investigated very clearly as a route to resolving the ongoing and increasing inequity of healthcare opportunities in our remote and rural communities. And we believe that in the university addressing this issue, that we are following through on the clear recommendations of the NAPFINE review of 2019 about the importance of education being purposeful and linked to place-based solutions for remote, rural and regional communities. Chair, thank you.
Thank you very much, Professor, for that very precise and clear opening statement. Can I move to Dr. Giddings to invite him to make an opening statement?
Thank you, Chair. As mentioned, I lead an organisation called RVTS Limited, which operates the Commonwealth-funded Remote Vocational Training Scheme. Now, this organisation has been operating for more than 20 years. It's a national program and operates to retain, chiefly to retain doctors in rural and remote locations, mostly smaller locations. And you will have heard, I'm sure, over the course of proceedings, the M classification for remoteness. And RVTS eligibility is for doctors who are working in M 4 to 7. So that's very small towns to very remote towns, and mostly in Triple M5, which is really very small towns. And over the years, the Remote Vocational Training Scheme has serviced more than 400 communities across Australia and trained more than 300 doctors in remote settings in place to achieve their specialist qualifications in general practice. Currently in New South Wales, there are more than 40 doctors in small towns across the state who are training with the program, training towards their specialist qualifications in general practice. And over the years, there's been more than 95 communities that have had the benefit of a doctor being supported by the program. The program, the nature of the program is to provide a full service postgraduate training program that would otherwise be delivered by the Australian General Practice Training Program. So our aim is to deliver training that is the equivalent of the Commonwealth-funded Australian General Practice Training Program, which is the default program for receiving general practice training and allowing doctors to become specialist general practitioners and to be able to operate in a unlimited capacity across the country. We are able to do that by taking the training to the doctors that are already working in small communities, usually under workforce programs that have allowed them to fill a gap and obtain a provider number. So our organisation identifies these doctors, brings the training to them and retains the doctors in their small location for at least 3 or 4 years during their training, and in many circumstances for years beyond their training. It's been a very, very successful program, a small program, but very successful program with more than 90% of the participants achieving their specialist qualifications in general practice. It's chiefly, at this point in time, as time has gone on, it's become much more and more a program that where the participants are international medical graduates. And that's international medical graduates, of course, who've made Australia home and for whom many rural communities are indebted. As time's gone on, during the life of our program, we've seen a dramatic change in the numbers of Australian graduates working in these rural and remote settings. It's to the extent now that more than 50% of doctors in rural and remote Australia and New South Wales are international medical graduates. So we're very, very dependent on international medical graduates and are likely to be for many years to come, despite the fact that Australian medical schools have more than tripled their output of Australian medical graduates in the last 5 or 6 years. We're not seeing that translate into doctors working in rural and remote Australia, in particular New South Wales. So this shortage of doctors, of course, has been exacerbated by border closures in the last 2 years with the COVID epidemic, and has illustrated our dependence on international medical graduates now and the likely dependence well into the future. And the importance of this is that we need to face this reality and ensure that we support these doctors who are playing a vital role, and ensure that they're supported by receiving high quality education, and in return, we're fortunate, our communities are fortunate enough to receive loyalty and commitment over years, and that's been our experience. That's the Remote Vocational Training Scheme, a very successful program.
Thank you very much, Dr. Giddings. We'll now move to questions from the committee members. We've got approximately 10 minutes each, or perhaps just a little bit under, for each grouping, that is opposition, crossbench and government. Anyway, the Secretary will guide us on the precise time. So we'll start with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair. My first question is actually to Professor Haywood. Professor, we've heard evidence over the last 9 hearings of varying levels of support for virtual or e-health. Do you understand why there is some resistance or animosity towards telehealth in certain rural communities, and from nurses who find that they, in fact, the only doctor that they have is on the end of a video camera?
I think first level of resistance, both from our experiences here in Australia, but I've also been involved in setting up telehealth programs in Europe and in Africa. Telehealth is better accepted when there has been the opportunity for deep training, first of all, as opposed to it's added on to existing practice. So one of our arguments is about recognising the need for deep training, both of the practitioners, the healthcare providers, but also that the community are given some support to become familiar with how to engage about discussing their health and their medical issues using a telehealth model, as opposed to what they've probably experienced in other parts of their life, which is a one-to-one in-person engagement with the healthcare environment. So I think it goes back to Dr. Gidding's conversation, which is about the importance of place-based training and education, both for the patient but for the practitioner. That would be number one. Secondly, I think there does need to be an awareness that there are issues about quality of connectivity. So quite a lot of telehealth in rural communities and remote communities, the bandwidth means that it's got to be voice only rather than voice and image. And on occasion, that can be quite limiting. That's not across the whole case, but that is quite often the case for some individuals. And I think finally, it's about guidance around issues of who can be present in a telehealth consultation, a support person for the patient, perhaps, without conflict of privacy, consent, or confidentiality.
Does telehealth, in fact, how often does it actually become sound-only medicine? So that's the equivalent of an old telephone call, then.
That's quite significant, and it would be my personal experience living in the region that telehealth. I've had a serious mechanical injury, skeletal injury. Almost all of the care I received following my emergency access room with telehealth was voice only. So it's in person but voice only, if that makes sense, without the support of the engagement of an image in the way that you and I are engaging now, sir. And that's a high percentage of the interactions for patients.
Now, you mentioned in your opening statement a virtual hospital. Can you take me through is that an exaggeration, or what is, when you say virtual hospital, what do you mean?
So our design of it follows on from good practice that's been developed in the United States and Europe. And in fact, the United States particularly is now making inquiries about following our model. So we have what we call the Joint Operations Control Room. We have it at the moment in our Armidale Clinical School, the Tablelands Clinical School in Armidale. That is a system that has the ability to provide high fidelity engagement, both with the clinical practitioners out in the rural remote communities. It allows patients to connect in and out. And if it's operating at full capacity, we set it up that we could also run 290 nominal patient engagements. So we would have patients technically with sensors, so they'd have pulse sensor, blood pressure sensor, heart monitoring sensor, temperature sensor. Those kits are connected using satellite and cloud-based technologies. All of that data is aggregated real time into the flight deck, and there can be a clinical practitioner and/or specialist as required at the flight deck. So at full operation, we can fly in, as we do already, fly in doctors to the Armidale or Tamworth site. They can see the data and engage with the patients through the flight deck. But we also then have healthcare professionals that we have developed and are training in the community. So much the model that Dr. Giddens has described, at the moment our pilot is with Inverell. We have a relationship with the Inverell community. We have a relationship with the Inverell healthcare, and we are training our practitioners and our community to engage with the technology that we're providing, but to then be able to bring specialist advice and oversight, pathology monitoring, etc., from the flight deck.
Okay, but you've said that it's a pilot. So, in fact, when do you think technology will be, and the internet broadband services will be up to scratch where you could actually virtually confidently provide and examine, provide medical care and examine people? Because, in fact, we are sitting in state parliament here today, and two of us had connection problems in the CBD of Sydney. So, yes, I do admire your optimism, but how far off is this? How far off is a virtual hospital?
So we are running, we call it a pilot because we're working out there are logistics, there are partnership issues. The technology, with all due respect, so is already exists. We bought the technology, we invested in the technology, we bought 3,000 and odd different pieces of technology into Australia last year in anticipation of providing a support hospital care in the event of COVID coming into the community, because we don't have sufficient monitoring beds at our local hospital. So we put this up as the subsidiary medical support at the beginning of the pandemic last year, and it was active at that point and capable of patient monitoring in situ if that was required. So the cost of the ambient and ubiquitous technology that we're using has now dropped so far. So the monitors, the sensors, you can get basically a hospital in a box type kit that has robust, low cost, high fidelity sensors. You can buy the data acquisition and delivery kits at relatively low cost, and provided that you've got a center equivalent to our Tablelands. So all of the elements that you need to be able to do it already exist. What we need to do is have a commitment at a system level that it is a model of healthcare that we can support more generally. At the moment, we're running it as an education facility. We set it up as a support to community care in the event of the COVID pandemic, and that was set up in agreement with the Armidale Regional Hospital in March of last year. So we could run a 290-bed hospital if that's what we needed to do.
I had spoken to nurses at some of our remote hearings in Western New South Wales, and they said that they were called upon to use telehealth in very unusual circumstances, and they were quite uncomfortable with it.
Yeah.
They said they had a situation where they, in fact, certified a death of a patient through telehealth by showing the deceased patient to a doctor at the other end of the camera. And they also said that they preferred telehealth overseas when they had overseas doctors on the receiving end or the end monitoring it, because they were more alert because of the time change differences than Sydney ones in the middle of the night. Can you respond to that?
I personally don't have experience of that, but I have practitioner experience of that from work in other places, sir. So we ran for the United Kingdom government a project when I was employed by the Open University, which is about looking at exactly the environment that you're describing. For example, in the remote Highlands and Islands of Scotland, which is a very broad distributed area, which 10, 15 years ago was only at the beginnings of digital and cloud-based and satellite-supported technologies. There is, and I'm sure Dr. Giddens can share, there are quite considerable issues to be resolved about moving from what we describe as conventional in-person healthcare practices to those that are appropriate and support both the healthcare practitioner as well as the patient, or in the example that you've given, the deceased. So I'm quite familiar with the fact that I've worked in environments where I would take a picture of a deceased patient and I would do so and have that certified at the site by a witness, and then we would send that forward as part of the record of care. But that's quite a challenging thing to do if you are not used to that, and that you are conditioned to use what I would describe as the normal care practices upon the death of an individual within a medical care situation. So, or even if you were attending a home event where a death was being reported and you were attending to certify and confirm that. There are practices that we've all been brought up in, which are about the analogue, in-person, etc. You need different support practices and different training to do that comfortably and respectfully if you're going to use either a digital, so a fully enabled, or a telehealth model. And they are different. There are different things going on in each of those environments. But the end result is that you need slightly different training and slightly different customer practices. You cannot just bolt it on to what we all were trained to do when we were in, as I describe it, analog, abacus medicine as opposed to iPhone medicine, if I could put it that way.
But you would concede that there are certain procedures and certain examinations for the dignity of the patient that you would not want to occur on telehealth, or the patient would be reluctant to agree to.
I understand the question, and in the context of, for example, of Australia, then I can understand that, sir. But I have been present in Ethiopia, where primary healthcare and digital support for the delivery of a difficult birth was conducted with a primary healthcare practitioner, and the doctor sitting, as you just described, many thousands of miles away. And with the appropriate dialogue with everybody, all of that was the whole event was done using full visual, in-person, connected support. There are medical situations where it's almost impossible that you would consider doing that. One would hope that those, in inverted commas, critical and emergency situations would be those that would be managed elsewhere, but that's not the way that this occurs already. And there needs to be this journey, which is what's appropriate, what's not appropriate. How do you share that consent and inform a patient? And you and I both know that patients, when in medical and healthcare stress, or in a situation where they feel unsure, will respond to the authority of the medical practitioner attending and don't always feel comfortable to express or share what they understand. We hear it as a post-event survey outcome rather than it will be part of the experience at the time.
Thank you very much for that.
A pilot is about establishing what are the conditions under which this works well for the benefit of both healthcare practitioners and patient. I hope I'm being clear in my response to your question.
Thank you. I think we do have the chair back now. Chair, are you there? It looks like he's frozen again, but we will move to crossbench time. If the opposition has any more questions, they can put it on notice.
No.
I will start with my questions now. Thank you, the Honourable Walt Secord. I have a question for Dr. Giddings. In your submission, you mentioned that only 5.9% of graduating domestic medical students are considering future practice in a rural or remote setting. This seems incredibly low. Why do you think that this is the case? And given it's just that they're considering, do you think that the numbers are actually much lower in reality? Oh, sorry, Dr. Giddings, you're on mute. Thanks.
I beg your pardon. Look, thanks for the question. Yes, it is a disturbingly low figure, but our experience suggests that is actually the case, and I think there's lots of reasons why medical graduates don't want to work in rural and remote practice. But what we do know are reasons for situations where doctors are more likely to work in rural and remote practice, and that's where they've have rural origin. They've come from a rural background, and they've had rural immersion in training, so that their training, they've had exposure to rural practice, either at an undergraduate or postgraduate level. And I suppose an extension of that with our program, with the Remote Vocational Training Scheme, is that we have doctors that are already working in the location under a workforce program, and by offering high quality support and a high level of support and allowing them to achieve their specialist qualifications. So it's not a dead end career position, it offers career progression. We're providing that rural immersion as well, and with the happy coincidence of meeting community workforce needs, medical workforce needs.
Thank you, Doctor. You also mentioned in your submission that you've had quite a lot of success with targeted recruitment programs, which has seen full-time doctors recruited in 15 of the most hard-to-fill positions in New South Wales. And this is something that, you know, we've heard a lot about in this inquiry is, you know, the difficulty of recruiting doctors into certain areas. You know, what did you do to actually attract people to these positions, and you know, what can we learn from that?
So our program has worked over the years as a workforce retention program. So the vocational training support that we offer helps keep doctors working in their locations. But we've varied that model in recent years so that we use the training program and support that we would otherwise offer as part of the recruitment package for specific high workforce need locations that have been identified in conjunction with the state-based Rural Workforce Agency, RDN, Rural Doctors Network. And more recently, the Commonwealth have enhanced that by adding salary support to that mix, so that communities struggling to recruit a doctor that are identified for our program are able to receive Commonwealth funded salary support for a period of at least 2 years, 2.5 years into the program. And this, we've had quite a deal of success with this. We've only been doing this for 3 or so years now, and with a small number, but we've found it very, very successful in locations, many very, very hard to recruit to locations around Australia. We've had 3 locations in New South Wales where we've operated on this basis, and that's Lightning Ridge, Burke, and Dareton near Wentworth in south-west New South Wales.
Thank you so much for that. Just going quickly to Professor Hayward or Ms. Nisbet, you talked in your submission a lot about longitudinal placements, and given now we're sort of halfway through 2021, I was wondering if you had a quick update on how those placements are going, and if they've been affected by the COVID lockdowns as well, or the COVID situation in general.
So we are running placements through the Year 4 and Year 5 of our joint medical school programme with University of Newcastle. As indicated in our submission, we have initiated a collaborative endeavour with the Inverell community, both at the level of the community council as well as at the level of the community practitioners. And so that programme is working very successfully, and it would be, following up from Dr. Giddens' comments, it's our experience that if you can give medical students and healthcare professionals an extended experience in the community and in regional healthcare training and medical training, then they both enjoy that, relish it, and see a real career opportunity for themselves. We are actively engaging as a university to recruit medical school students with a focus on regional and rural medicine into the medical school programme. This year we had the highest number of Aboriginal students. So again, connecting back to Dr. Giddings' comment that those who work in community and live in community are more likely to be retained. So we've had 12 Aboriginal medical students. That's our highest number. We normally average about 6 or 7 a year from the community. It's now become a growing trend because we have an outreach programme that actually captures them as they're coming through the later stages of secondary school and moving forward. And we also privilege and specialise in scholarship support and accommodation support for medical students who are on the JMP, the Joint Medical School Programme, who will do their placements and their practitioner work here in the regional community. So we create incentives to support them to be able to be part of the community and to gain the lived experience of receiving their medical training within a regional, rural and remote context. And whilst it might be that many of those coming are, for example, drawn from large metro conurbations, the experience of our surveys is that once they're here, after the first couple of weeks, there is something that's opened up to them that they have not previously experienced. And it goes back to Dr. Giddings' comments about why is it a problem to move people through? If your entire medical and healthcare professional have always been trained in metro large system facilities, then all medical students are being trained with that medical system in mind. And part of the Nevin concept is to be aware that quite rightly our medical system is trained to give this view, and the people providing the training have experienced this version, in my language, the analog version of medical health experience, medical health professional care, and the training of medical and healthcare professionals. If you shift the model of training, both of those who will do the training and those who will be trained into a different environment, that becomes the norm rather than something exceptional or other. So part of the data are about what people experience and the environment in which they are trained. And it is our argument that by increasing the opportunities for people to receive place-based education, so training and development of their careers within the context of where those careers will then be lived, and that is not a deficit model or some secondary option, that is a genuine option within the totality of the healthcare and education programs. That's where you start to see the real shift in numbers. Australia is not the only nation with this problem. Other nations have wrestled with this issue, and we can learn from their successes and adapt them into a model that's suitable for Australia. And the Nevin is very much based on drawing good practice from other examples where the same healthcare issues and healthcare deficits have had to be resolved.
Thank you.
Thank you, Professor. So, sorry, the line dropped out again. Are we over to Kate Fairman?
Ms. Fairman. Yeah, thanks, Chair. I'll actually give my questions over because most of my questions have been asked, and I know government members will have some interest in this topic. So happy to cede my time there.
Thank you, and we can circle back, Katie, if you'd like to do so. There's something to tidy up. So we'll move then to government members. Who would like to start off? Honourable Trevor Card or Westphal or
I will.
Natasha? Which government member? Honourable Westphal?
Apologies, Chair. Sorry, I was just trying to bring my mouse across to get the to the mute button. Well, thank you very much for your evidence today and your submissions, both of which are really detailed and provide a lot of clarity for us. Look, I just wanted to delve into some of the issues that the Honourable Walt Secord was talking about with virtual medicine, and it has throughout the hearing, I guess, attracted some negative feedback, but I'm wondering if you might be able to provide some of the positive feedback that that you've experienced from being able to look at virtual medicine and the advantages to communities.
Who would you like to direct that to?
Oh, sorry, you're on mute. Sorry, thank you.
I don't know. I think you're framing it to both of us. So I've played around with the mute button faster than Professor Dr. Giddings has. The positive experiences. Thank you. So here in our environment, it is the first part of it is that we engage in a collaborative discussion with the community. So a lot of telehealth was the provider made that the only offer available to the patient, and the patient receives it, as I said earlier, with no support. I think one of the things that we are seeing very clearly from our model is the fact that there is an engagement, that we share We share the construct of the model. We have demonstrated the model to in various ways to the community, and that we have made sure that our healthcare professionals who are supporting and developing this model go out to the communities and demonstrate how it operates. You're not receiving it as de novo in the first time that you need a healthcare intervention or healthcare support. We have operated on the basis that the education and training component has to lead out in the delivery of the whole of the rest of the model. And the data that we have clearly supports that and would make it as an outcome of our pilot work. And Leanne Nesbitt, who's with me, is a doctoral student, a mature doctoral candidate, who is looking at these data so that we can give advice on policy developments going forward. That's the object of her doctoral candidacy, and she is one of the people that goes out and takes liaison. So she may wish to comment on the conversations within VREL, for example. But I was also, as I mentioned earlier, associated with setting up a primary healthcare network using digital and virtual technologies in Africa, for example. First of all, people want healthcare, and they want, you know this as well as I do, they want healthcare in place. And if you engage with a conversation with them about healthcare in place and how that might operate, and you do so and you outline what the opportunities and advantages of that are, rather than it's seen as being a deficit model. So going back to the earlier question, some of the visible anxieties in our system around telehealth is that it has been imposed in a deficit condition, a response to a pandemic, but let's call that a deficit condition. And we've gone from here to here without a great deal of guidance or education or development as to how you as a patient, you know, might have a little checklist of things that you need to walk through with your healthcare practitioner or your medical provider when you are preparing for the telehealth interview, and then you are progressing through it. We did no development work with any of our patients within the system as we moved into telehealth. That's not a criticism of a fantastic response in the middle of a pandemic, but I come from an environment where you know, we would be supporting 250,000 students a day through the Open University. We would not engage with them without going through a process of induction and guidance. And the work we did with the National Health Service to build their telehealth provision was about making sure that there was training and guidance for both agencies, the patient and the healthcare provider, the medic. There was specific training about the process of having a telehealth interview, a telehealth care case management conference for both parties. And even as simple as just having a checklist in front of you, so that you, the patient, knew how to conduct yourself in that situation. And we're not overwhelmed by the anxiety of both engaging with technology, but listening to questions without being able to pick up the normal emotional intelligence and the emotional signals from face-to-face interactions.
Thank you for that. Did you want to expand with on that, Professor Giddings? You look like you wanted to make some contribution there.
Yes, look, I would support that, and I suppose our doctors who are being supported and in training. Telehealth is a great adjunct to what they're doing. It's part of the package that makes their positions sustainable. I'll give you an example. Doctors Salma Hanif and Kamosha Abakawera are the only two doctors in Boggabri, and they are doctors in our program. They've been there for a couple of years now. They're doing a wonderful job, but they're providing a 7-day-a-week, 24-hour-a-day service. It's just not sustainable. And particularly when there's a community expectation that there will be 24-hour care, after-hours care, this is where telehealth is of great assistance, particularly when it's supported by other practitioners, such as nurse practitioners, ALS-trained nurses and paramedics who can receive telehealth support at a distance. And you know, whether that's from Tamworth or Armidale or indeed from Sydney, there are, New South Wales does have already has some very good telehealth networks in place which provide excellent support. And indeed, with our training, much of our training is tele-training, and if you like, it's tele-education. We do tele-work-based teaching, tele-work-based assessment, taking advantage of technology that's around. And I must say that internet support across New South Wales is generally pretty good. And even the smallest towns have at least a 4G Telstra tower these days. It's very uncommon not to have that. And so it means that it is possible for us to be able to use technology to support doctors in this role. But there's no doubt that what our communities want is a doctor on the ground. That's their first preference. They want to have a face-to-face doctor on the ground consult. But if they can't have that, then this is a wonderful adjunct that we can have by utilising technology. So fully support what Professor Hayward is saying.
Thank you very much for that. And I'll just pass over to my colleague, the Honourable Natasha McLaren-Harris.
Thank you very much. Virtual health is not new, and it's been talked about for close to a couple of decades in Australia. But Professor Hayward, you did mention we've had to move forward a lot quicker with the pandemic. What I'm interested to know from all our witnesses is where can virtual health go long term, looking at particularly international experiences. Where can Australia go in the next decade or more to come? And what do we need to do to get there?
Well, if I had my way, we would recognise the value. So I'm support Professor Giddens' conclusion, and I work and I visit these communities. Each community wants its own GP, but to the point being made, one GP, cannot deliver at the level that's required. So I think there is a debate about rethinking what the role of the GP and the healthcare unit is, and at what level and what density you need those in settlement, what settlement index and what density you need people. But the virtual hospital means significantly for a lot of the communities that we deal with, that you can talk to a consultant about, a medical condition, and you don't have to leave your family and go to Tamworth or go to Sydney or go to the Tweeds. A lot of what we're asked to do is to travel 3 or 4 hours in order to have an appointment that might occur in 8 to 9 weeks' time. That's the reality. No matter what the data might be elsewhere, that will be the conversation that most commonly we are managing about the availability of healthcare and the frequency with which people can see it. And we all know that there's only one pot of money, in inverted commas, and it's never big enough. So the Nevin is one way of looking at the solution, which is we, for example, my vision of this is that Tuesday is orthopaedic day, and the very best orthopaedic advisors, surgeons, whatever, are all flying into the Armidale. We call it the flight deck, the mission control. They're all up there on enormous connected screens. And then every community knows that this is orthopaedic day and that there will be a connection at a community level to do the orthopaedic consulting, etc. And that will be a constant. That starts to do some of the things that Dr. Giddens referred to, which is about the continuity and assurance of provision. And if you can't do that by having enough people, and you always have to be moved out of your home environment to go somewhere quite remote with all of the cost that comes with that, then you won't participate. Whereas if it's provided, and you make the incidence of availability lower energy, you catalyse that access, then first of all, we will see an increase in healthcare outcomes, because the disability data at the moment and the disability year index for our communities, do not reflect well on Australia, let's be honest, and others with fewer resources are overtaking us. But also people more actively will engage in ownership of their healthcare. The Inverell model, it follows on from what Dr. Giddens has just said, which is the community takes responsibility for healthcare rather than assuming it's somebody else's responsibility. It becomes a collaborative endeavour. So that would be my vision for a future, that it may not be our model, but some version of our model, fit for purpose in an Australian context, means that if you're in your Glen Innes, which is an hour and a bit drive from here, or 2 weeks ago we were up in Moree, we got the police to bus people from the mission to our open clinic, if you will. So we do that as a community. We didn't wait for the health service to provide a bus to take people to the clinic. The community said, this is what we're going to do today. And the community came together and provided the resources to make that happen. And our job was to make sure that the clinical opportunity was sitting there waiting for people at the right level of quality and expectation when they came to that site. That's a different model. That's taking the hospital to the people rather than asking the people to travel to a hospital. That's the vision of difference. That's not for everybody, but that's for rural communities. Apologies, Chair, I will be silent.
No. Thank you, Professor. And listen, on behalf of the committee members, can I thank you, Professor Haywood, Ms. Nesbitt, and Dr. Giddings. It's been most informative. Your submissions whetted our appetite, but to be able to speak to you directly and pose questions and involve in an exchange of back and forth with you always been most valuable. And once again, on behalf of the committee, thank you very much for your participation in the inquiry with respect to both submissions and oral evidence today. Thank you.
Thank you to the inquiry.
Thank you. That concludes our public hearing today. On behalf of the committee, can I thank all members of the community who may have joined us over the internet. This is an ongoing inquiry. We're getting towards the end of it, but we still have some hearing days to go, and we hope that you will consider joining us again when we next come together in the not too distant future for the next public hearing. Thank you very much. Can I ask committee members to stay online, please, for a very quick deliberative meeting?